So, welcome to today's event, Filling the Gaps, How Might Business Support Access to Healthcare? Thank you to those of you attending here in person at the Globe and Mail, and we also have a very large audience attending virtually today from across Canada. My name is Andre Picard. I'm the health columnist at the Globe and Mail, and I'll be your co-host and moderator today, along with my colleague Carly Weeks. At this point in the program, we always do a land acknowledgement, which all of you have heard many times because you attend conferences. We're gathered here today on the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and Wendat peoples. And Toronto is now home to many diverse First Nations, Inuit, and Métis people. Now, the purpose of this gesture is not just to get it out of the way. It's to help us reflect on our role, both individual and collective, in reconciliation. Today's event is focused on healthcare, so I want to read you one of the calls to action from the Truth and Reconciliation Commission. This is number 19 of 94. I'd suggest you read the other 93, but I'll just do one today. We call upon the federal government, in consultation with Aboriginal peoples, to establish measurable goals to identify and close the gaps in health outcomes between Aboriginal and non-Aboriginal communities, and to publish annual progress reports and assess long-term trends. Such efforts would focus on indicators such as infant mortality, maternal health, suicide, mental health, addictions, life expectancy, birth rates, infant and child health issues, chronic diseases, illness and injury incidents, and the availability of appropriate health services. And I'll just note that this has not been followed through on yet, unfortunately. So now I would like to invite the person to recommended that I do something more than just a token land acknowledgement, our friend Elder Wabigoon, who is going to officially open the event. She's an Ojibwe elder who sits in the Loon clan, a keeper of the sacred pipes, a member of the Lac Seul First Nation, and a 60s scoop survivor. Elder Wabigoon is a writer, speaker, land defender, and water protector. She's also founder of an elder for NDG, Nikibi Dawidana Gigwag. I'm getting better, I think, each time. That's an Indigenous youth employment program, and she has an advisory role with a number of institutions, including the City of Toronto and Street Art Toronto. Please join me in welcoming Elder Wabigoon to the stage. Oh, yes. Please accept this gift on our behalf, and please welcome our delegates to this conference today. Thank you.
Thank you. Ani and the way Magana talk. Bonjour. The Comus Wabigoon Indigenous, a Bishop Kokang, Lac Seul First Nation, meanwhile Toronto, Indunjiba, and Mangdoram. What I said was an Ojibwe protocol greeting, and I said, hello, all my relations. My name is Elder Wabigoon, flower blooming in spring. I'm from the Narrows abundant with white pine, and a member of the Lac Seul First Nation, and I've resided in Toronto for 46 years, and I sit with the Loon clan. My husband Carl and I, who's here today, would like to say miigwech to the Globe and Mail and GreenShield for the invitation to open this occasion, and would like to offer our thanks to the event planning team for welcoming us so graciously to this event. I want to say miigwech to Andre for offering me the tobacco to say some opening words. Tobacco is sacred and is one of the first plants that Creator gave to the Anishinaabe people. We use this plant in sacred ceremonies as offerings for opening and closing events such as this, and I humbly accept this tobacco. So whenever we gather in a place such as this, and we want to open this beautiful, stunning space, we want to open it in a good way. We want to fill this space with ease and with balance, good words, good direction, and come together as one. What we share and what we listen to today will affect the next 7 generations. The next 7 generations is a Haudenosaunee teaching. And if you don't know the meaning of it, please look it up. Normally, I would open a space To open a space such as this, I would smudge it with sage smoke, and I think some of you have seen that. But today we'll be opening with Mushkaki Nibe, sacred medicine water. I chose water to open this afternoon because I want to have everybody to have access to it, and to recognize and to be grateful for water, not only today, but every day. By saying miigwech, by saying thank you, the next time you take a drink from your glass, or when you wash your hands, or perhaps it's later this evening when you shower, making that last cup of tea. Go out onto the balcony and whisper or yell or sing to Lake Ontario. Say hello, acknowledge that water. I brought with me this afternoon a mixture of cedar gifted to me from the trees that sit on Vancouver Island. And it includes sacred medicine stones from the Bulkley and the Skeena rivers where they meet at the Great Kazan in British Columbia. This is called Mushkaki Nibe, medicine water. I share it with you now with this space, and I want to call out and honor the sacred water that sits close by, Lake Ontario. We want to remember those who came before us, as told in many creation stories that we have. And I speak of the earth, the wind, the fire, the water, the winged ones, the swimmers, the crawlers, the green nation, the plants and the trees, the four-legged, the buffalo, the bear, the great antlered ones, just to name a few. That word, Indewemaganadag, means all my relations. And that's what I mean when I say that word. I'm not just talking about the two-legged. I'm talking about all those beings on Mother Earth, all my relatives. And I recognize them as a sacred part of creation. And that's what gives me that relationship to them, is I realize that we are so connected. You too can have that experience if you take the time to talk to the squirrel, to talk to the trees, to talk to your water. All these beautiful things that you could do. It's a wonderful way of life and a wonderful experience. So, as I sing this song to open the space, and because you are still eating, I won't ask you to stand for this song. But I ask that everyone think about what you're grateful for. In your mind, say miigwech for the land you walk upon, that you live upon, that you work upon, the water so sacred. The colorful trees letting go of their leaves, teaching us that it's okay to let go. The animals preparing for the long fast, that crisp wind that refreshes your face. And while we sit under the 11th moon of creation, Mushkaka Jesus, look up from your technology, for the star nation sits closest to us during this moon, making it brighter in the evening, bringing it closer to our ancestors, as we believe that we are from the star nation. So it's your ancestor, your ancestor, your ancestors are so close at this time. If you look at the moon, you'll see that it brightens the sky at nighttime. And those stars are very close to us. So the words I'm about to sing are, water, we love you. Water, we thank you. Water, we respect you. As I sing this song, I ask you to visualize a lush, green Mother Earth and clean water for the generations to follow. Visualize hope for those with too much water and prayer for those with not enough. If you know this water song by Mash Kuntz and his grandmother Doreen Day, please join me in singing it. They have generously gifted us the permission to share and sing this Nibi song wherever we are, and we say chi miigwech to them. So as the sun does. We always start in the eastern direction. Nibe gishake hiko gi mekwechoe ni miko gishawe ni migo. To the southern direction. Nibe gishake hiko gi mekwechoe ni migo gishawe ni migo. To the western direction. Nibe gishake hiko gi mekwechoe ni migo gishawe ni migo. Lastly, to the northern direction. Nibe gishake hiko gi mekwechoe ni migo gishawe ni migo. So it's with this song and these words that I urge you to remember the spiritual connection that we all have with Mother Earth and the water. To live the lesson that shows us of living in harmony as one with all our relations. If you look at the trees, they live in harmony. The fish under the water, the swimmers, they all live in harmony. I say miigwech as I honor those who came before me, and I say miigwech as I open this space. Apachiko chi miigwech bisandawyeg. Thank you all very much for listening. Miigwech.
Chi miigwech, Elder Wabagun. Thank you again for being here today. Before we get started, I want to do a couple little housekeeping notes. I want to thank our principal sponsor, GreenShield. I want to remind you we have Wi-Fi here. Look for Globe Events, and the code is GlobeandMail @9. If you're tweeting or using social media, please use our hashtag GlobeHealthGaps. And before we begin, I also wanted, there's going to be some polling today. We want to get some audience input on what we're talking about. So to participate, just scan the QR code that's on the card in the middle of your table. And if you're on the screen virtually, you'll see that QR code. Please take us a few seconds to do that, and we'll try it out a little later with a poll. You know, today we want to talk about two things in particular: gaps in access to healthcare and partnerships in healthcare. More specifically, how public-private partnerships can help close those gaps. While Canada has a universal health insurance program known as Medicare, and much of our care is publicly funded, about 70% of it, a lot of people still fall through the cracks, unfortunately. We're going to focus today on some areas where access problems are the most acute, such as dental care and mental health care. We'll pay particular attention to marginalized populations, such as Indigenous peoples and immigrants and refugees. Our goal today is to explore how we can bring more partners to the table to lend their expertise, funding, and resources to help fill those gaps. So it should be an interesting event. So let's start by setting the stage a little bit and talking more about where the gaps exist. To tackle this topic, I'd like to invite two people to the stage to join me. Kathleen Morris is the Vice President of Research and Analysis with the Canadian Institute for Health Information, known as CIHI. And Zahid Salman is President and CEO of GreenShield Canada. Thank you both for being here today. And I also want to test your polling fingers. So let's start with one little question. In your experience, what is the biggest underserved area in Canada's public healthcare systems? And there's a multiple choice answer there. You don't have to dream one up. So you can vote, and I'll give you a few seconds to do that, and we'll see what the results look like. I think mental health is winning by a long shot here so far. Illness prevention is catching up. It's a tight race. Dental care, prescription meds, women's health. So quite a few access problems. I think mental health is going to be our number one. We'll see what our panelists think about that one in a second. So I want to try, if I could, Kathleen, start with you. You're the data person here from CIHI. Can you tell us a little bit about, where are the biggest healthcare gaps? Did our audience get it right? Is mental health number one? Where else are we seeing the gaps?
Well, I don't think that there's actually a single answer to that, Andre. It all depends on really who you are, where you live, and what your family needs. I think if you were to ask, though, regular people on the street, and what we would hear is that access to care is a huge issue, and it's more of an issue in some ways than people worrying about safety or efficiency, for example. The gaps could be anything. It could be if you don't have a family doctor, it might be access to a family doctor. I think that the audience vote for mental health is definitely one that many people worry about. And I think if you're waiting for surgery, that again could be something that you're very concerned about. And I think maybe the point I just emphasize is if you're in a situation where you're waiting for something that you can't get, you feel awful. And I was struck last year reading a story about an elderly woman from Victoria whose husband had run out of his anti-seizure medication, and they didn't have access to a family doctor because theirs had retired. So she had actually taken out an ad in a newspaper trying to find someone who could help. And I just think that's a sign of how awful and desperate it is when you're waiting for something you can't find.
And is there a simple explanation to these access problems? Is it, we often hear the term postal code lottery, they depend on where you live, but are there other ones?
For sure, and we'll probably get into some of those today. There's income, there's education, there's many things that influence things, and I think one that'll be of great interest to the group here is whether or not you have to pay for services and whether you have benefits that cover those.
And that's a good segue to Zahid. I think, we've heard some of these gaps. We saw the audience polling. Where do you think, how do you think people are feeling these gaps, and how do we address them?
Yeah, it's a great question. So first, I'm happy to be on the panel today. I'm an actor by background, so it's the first time I've been on a panel and not being introduced as the data person. So thank you for taking that responsibility. I think there's, as Kathleen was saying, there's a number of key gaps in the system today. Accessibility is a big one around all sorts of different disease states, whether that's just visiting a doctor where 1 in 4, sometimes 1 in 5 Canadians don't have access to a doctor. Those that do often have to wait more than a week. A third of Canadians wait more than a week to see their doctor, right? So part of how they experience it is creates anxiety because they just can't get in front of a health professional. That's a doctor, that's a counselor for mental health. A third of Canadians don't have access to dental coverage. So I think that creates a lot of anxiety and really impacts care. And all those access issues are even worse when you think about marginalized and equity-seeking groups, right? So the most disadvantaged and underserved members of our society, those access issues are exacerbated even more, which keeps them in the cycle of poverty and marginalization that we all want to help them lift from. So I think that's one big part of why this is such an important societal issue that goes beyond health. And then another big one is just the whole fragmentation of the healthcare system. So as the population ages and more people have chronic health issues, mental health now accounts for about 20% of chronic health conditions in the country. You need to see multiple different providers, and our system is very fragmented in that the data is not interoperable between providers. There's no sharing of data between the public and private sector, so it's hard to really form a care plan and measure are you actually improving health outcomes with some of this. So if our goal is ultimately to create a patient experience that's centered on patient-centered care, personalized care that improves the health experience, all these are barriers to actually achieving that end goal, I think.
So if we want that patient experience, where do we start tackling these gaps?
Yeah, so I think there's a few potential solutions out there. One is obviously the healthcare system is very overburdened. There's just not enough healthcare practitioners to really serve the need. So I think technology is a significant potential lever for that. Obviously, we want to get more practitioners into the system. That'll just take time. But technology is at a state right now where I think it can really accelerate the overburdened nature of the healthcare system by automating a number of tasks and creating more time to spend directly on patients. The introduction of digital health solutions has the potential to really revolutionize access. We really need legislation to allow it in a more fulsome way than is permitted currently. And then I think public-private sector collaboration is really important. You mentioned in your opening, Andre, that 30% of healthcare is delivered by the private sector, but there's not really enough collaboration between the two. I think some of that comes from our philosophical view that all healthcare should be delivered by the public sector in Canada. And even if that's our view, that's fine. But there's an opportunity to partner such that the private sector can enable the better delivery of publicly funded healthcare. So I think that's another great opportunity that we have to improve the experience.
And we'll come back to that one in a minute. But I want to ask Kathleen, CIHI has been at this for a long time, this measurement business. Are things getting worse? The perception out there is it's getting worse, or is it about the same, the gaps?
I think a lot of the gaps at a minimum are persistent. That we don't see them getting better over time. And an interesting example for that might be in dental, where one of the things that we look at over time is the number of kids, young kids, who haven't had access to enough basic dental services, and they actually end up touching the public system in terms of hospitals. And they have so many cavities that they need anesthesia and need to have their cavities treated in hospitals. And you'd think that that could be a small number, but it's actually, when we looked at it 10 years ago, it was 19,000 kids under the age of 5. So it's a lot of kids, really wrestling with this. And those are all, as you can imagine, potentially preventable issues that could be resolved if the care had been more available. And that, again, when we talk about equity, that disproportionately affects kids in poorer communities, about 2.5 times more than in the highest income quintiles. So I think that that's an interesting thing. We looked at it again 5 years later, and this time we focused on big cities in Canada. And what we found is a 10-fold difference in the rates of kids needing hospitalization for filling cavities. The rate was, Edmonton was the leader, Saskatoon was at the end. And we were trying to figure out the why of that. And we don't do this when we publish data by hospital or by community. It's not to sort of name and shame. It's really around creating this learning health system. And what we found is Edmonton had a long time public health commitment to dental care. They'd had fluoride in the water since 1966. And they had a school screening program. So there was a lot of activity that actually led to good results that other communities could learn from.
Yeah, so you provide the data, and that's my job to do the naming and shaming, so thank you. So Zahid, let's stay with dental, because it's a really good microcosm of the bigger system. We have this mixture of public funding, private funding, and now we have this big dental program coming. Is that the way to go? Should everything be public? Should we keep this mix of public-private? What works best?
Yeah, I mean, it's a great question. It's one that we have been talking about a lot since discussions have started about dental care. So I think, well, first of all, what's the problem we're trying to solve? The issue is that 1/3 of Canadians lack access to dental care because they don't have coverage under either private or public plans. So really, I think the focus needs to be on that group as opposed to reinventing the entire system and breaking what's working well. Let's focus on the subset of the population that don't have access right now because of a lack of coverage. And I think it's great what the federal government is thinking of. Let's start in a phased approach and really build out more coverage and eventually get to the point where no Canadian has to go without dental coverage. The latest statistic I saw was that 1/4 of Canadians go without dental care because of issues around cost. And every Canadian deserves affordable access to necessary dental care. And I think there's a number of ways that the public and the private sector can collaborate to deliver that. The private sector obviously has a lot of experience in administering and managing plans that not just provide the coverage, but then provide the reimbursement. And then obviously, we can work with the practitioners to really deliver that care. And we've been doing this before at GreenShield, before this Canadian Dental Care Plan was envisioned, in that We've committed about $20 million to oral health in Canada to do two things. One is research. So we're collaborating with the University of Toronto to do a research study on the importance of oral health and overall health. So public policy makers have that data to really commit and expand these programs. And the other part is we've partnered with a number of community resources to now fund about a dozen oral health clinics across the country that are really focused on delivering oral health care to this group that we call the working poor. So these are people who make too much to qualify for public oral health plans, but don't make enough to prioritize spending on oral health above food, housing, things like that. So we're delivering care to these Canadians in need. I think that's a great example that potentially the federal government can look at as they scale up a dental plan nationally.
And at GreenShield, you're a private provider, but you're a not-for-profit provider at the same time. People don't always make that distinction.
Yes, that's right. So, I mean, really the social mission that we have and the reason the company exists is to deploy our excess earnings and our service capability to help drive better health for all. So we have a strong focus on oral health and mental health and really helping fill the gaps in the system for those who lack coverage today.
Somebody likes that. Talk about the mental health part as well, because a lot of people, there's a big demand for mental health, but a lot of it is paid out of pocket. And insurance, I know it's a debate in every workplace, and a lot of employers don't cover very much, like $300 a year or something.
Yeah, and I think what's happening in the workplace around mental health is really a function of what's happening in broader society. So for the longest time, there's been a stigma around people self-identifying as needing mental health care. And I think a great job is being done, particularly over the last 5 to 7 years, around removing that stigma so people can really identify that, yes, I need help. And then obviously there's a real challenge with publicly funded healthcare and mental health resources in that there's not enough capacity to meet the growing need as the stigma is lifted. So I think many employers have really started to take that to heart, and they prioritize mental health in the workplace as an area to invest, both to attract and retain talent, but also to improve workplace productivity. Studies have been done that shows that workplace investment in mental health often returns 2 to 3 times that initial investment. So more and more employers are buying into that now. So as we've diversified our business, have gone from just paying claims now also delivering healthcare services and trying to seamlessly integrate the coverage and the care. And mental health is really where we started. So we've seen through the pandemic an explosion in the use of mental health services. They increased about 75% from pre-pandemic to post-pandemic. And we've invested in counseling services, therapy services to really meet that need. And then from a social impact perspective as well, one of the things that we saw during the pandemic was while every Canadian's mental health was adversely impacted, there was a disproportionate impact on women's mental health because the burden for things like childcare, elder care disproportionately fell on women. And if you look at the data, women tend to have a harder time accessing mental health support. So we created a social impact program that delivers our therapy and counseling services at no charge to any Canadian woman over the age of 18. And just to show you the demand that's being latent there, already in just 2 years, 75,000 women have accessed that program. So there's a huge need, and I'm happy to see that more and more people are making avail of it, and that employers are investing more in mental health supports now.
And we have some really interesting public-private partnerships in mental health that we'll be talking about later today. I want to go to you guys for questions in a second, but Kathleen, while you're getting ready, raise your hand, we'll bring a mic to you. But Kathleen, I want to ask you about, are there also gaps in data? And if so, what do we need to know that we don't know?
Yeah, so I think that we're, we often say that we're kind of data rich and information poor, and that's really a challenge. We have a lot of data. We have, there's 50 million emergency visits, there's 600 million prescriptions filled, so all kinds of activity on that front. But I think what we don't have, as when we saw it during COVID, is we didn't have the basic data to answer even some of the most straightforward questions. One of the things that we see is that the challenge is not that the data doesn't exist, but we can't use it together. So for example, your family doctor doesn't necessarily record things in the same standardized way using the same information systems. So it's very hard to get a complete picture. And when you don't have a complete picture, you have uncoordinated, delayed treatment, you have duplicate tests, lots of things just don't go well. So what we need is,
connected systems between public and private, between different parts of the public system. And whether you're at a primary care clinic or at a dentist or at an emergency room, the person treating you should have appropriate access to the information they need to give you safe and effective care.
And of course, the data matters. There's a saying in the business, if you don't count it, it doesn't count, right? So it matters what we measure.
Yeah.
Now I see some hands up, but I don't see the person with the microphone. There's someone over here. Oh yeah. And you guys will have to wave a little louder for me to see you. So.
Compelling conversation. Distilled, my take on this is the deficit in what I call political leadership transformative in terms of doing what ought to be done in the greater whole as opposed to transactional, to be elected or re-elected, because the waste is inherent. And there are certain fundamentals in what I call our civics, and health being one, and then our defense and foreign policy being another. But the issue is that we need governance that's going to be aggregated long-term as opposed to reinventing, because health is fundamental in terms of what I call our sound civics.
Great, thanks. So Zahid, I'll rephrase, are we acting enough on what we know?
Yeah, I think there's a tremendous opportunity for changes in public policy to help resolve some of the issues that we've been talking about in terms of gaps in the healthcare system. For me, there would be three main priorities. The first would be, from a policy perspective, really being able to encourage public-private sector collaboration. We've done it in Canada in the past when it comes, these P3s that have been set up, but they're largely based on infrastructure, as private capital funding new or upgraded healthcare facilities. But what about from a service perspective, right? So how can we all get comfortable with a system where the private sector can add capacity, innovation, and technology to help deliver publicly funded healthcare, so that no one's paying with their credit card, they're still paying with their, in Ontario, OHIP card, but we're benefiting from this capacity and scale that the private sector can bring. So that would be one. Another one would be to encourage virtual health adoption, because that really has the biggest opportunity to revolutionize access to care. And some of the legislation in some of the provinces is still really restricting digital health solutions, particularly as we emerge from the pandemic, which to me seems a little bit backwards. And then the third is from a data perspective, right? Really having interoperable data between the private and public sector that goes across practitioners, so that you can have a patient-centered data record that can go with them every practitioner that they visit. I think that public policy can play a significant role in enabling that.
Good. I see another question here. We have time for another question. So.
Thank you so much. I really appreciate what you said about sharing data and information. How does the federal and provincial governments work with municipalities to, and maybe this is a question for Kathleen, share preventable illness data so that municipalities can actually help with zoning ordinances to make sure that they have walkable healthcare, walkable mental health, parks, and that their zoning is actually connected with healthcare outcomes?
So I think that that's a great question, and I think that the answer is probably it happens differently in every province, because that's really where the locus of responsibility for healthcare is. It's interesting, though, there's people who are proposing taking a more principles-based approach. So if you kind of look at the Canada Health Act and you say, people like it or don't like it, but in general, there's fundamental buy-in in some of the principles that are underneath it. Like portability or equity, that are enshrined. And I guess there's a sense, too, that there's a group during COVID that came up with a Pan-Canadian Health Data Charter that actually spoke to information sharing using those kind of principles. And I think the more work that we could collectively do on that front and sort of supporting some of the principles there actually would take us a long way to getting data in the right hands to make good decisions.
And Kathleen, one last little thing on data. How is technology going to change data collection? Like we all have wearables now, we have AI coming. Are we going to have way more data, or is it just going to become more complicated? or both?
I think probably both, but we'll have way more, which is a good thing. And it's only going to be good, though, if we can figure out standardized ways to capture it and share it. And I know people often kind of like their eyes glaze over if I talk about standards or data sharing rules, but they are foundational to make sure that we get the best outcomes and make the best use of the information that we have, because I think too often now people make decisions based on gut decisions, and the data's there, and it just needs to be assembled in a way that we can really put it to work.
Great. I know Zahid's eyes don't glaze over. He loves that stuff. But, so please join me in thanking our first two panelists, Kathleen Morris and Zahid Salman, for joining us today. Thanks. Our next panel is a panel of business and community leaders who will talk about how to approach public-private partnerships, some practical stuff. So let me introduce them. We have first Robert Trewartha. He's Director of Strategic Communications and Initiatives with the City of Mississauga. Welcome. Next, we have Helen Siebel. She's Head of Employee Community Giving at BMO Financial Group. You just stole my chair. Okay. Oh, well. Next is Dr. Andrew Bond. He's the Medical Director of Inner City Health Associates in Toronto, one of Canada's largest community health organizations, and it's focused largely on population health equity. If you saw your program online, you will know that Audrey Rochette was going to be here, the Executive Director of the Anishinaabe Health Foundation. Unfortunately, at the last minute, she was unable to make it because of a health emergency, so we hope to have her back in the future. So I'm also going to put you guys to work again with another audience poll. So here's audience poll number 2. Are you familiar with public-private partnerships aimed at improving healthcare access for underserved and marginalized communities? And this one's easy, yes, no, or I don't know. So yeah, pretty good familiarity. I think that probably is the audience bias. That's why you're here, but good. But still, we're going to learn a lot. So about half the audience is not too familiar with this, so we'll give them some education. So you work with the City of Mississauga. You have this great initiative called Cities Changing Diabetes. Can you tell us a little bit about this and why did a city like Mississauga decide to tackle diabetes?
Yeah, it's a great question, and I look across this room and there's a lot of healthcare experts, and you're probably wondering why there's somebody here from the City of Mississauga. But we partnered with Novo Nordisk on the Cities Changing Diabetes Challenge about 2 years ago. Today is actually World Diabetes Day, so this is an apt time to have this conversation. But Mississauga is a city that's almost 50 years old, and if you've ever been there, you know that we are a bit of a sprawling city that's very car dependent. We also have some of the highest rates of diabetes in the province, in some cases 50 to 75% higher than the provincial average. And we started to say, well, how do we tackle this? And Mississauga is a lower tier municipality. We belong to the Region of Peel for another year until that is dissolved. That's a whole other conversation. But we don't control public health, but we do control many of the things that will work towards prevention of chronic diseases like type 2 diabetes. And so we were trying to figure out how to get into this program, and Novo Nordisk approached us. They are one of the largest manufacturers of insulin in the world, and they said, well, we actually have this program. It's 40 cities. It's been around for about 10 years or so now. And it's really a partnership between the Steno Center for Diabetes in Copenhagen, as well as University College London and Novo Nordisk. And they work with cities around the globe to try to find ways to tackle head-on type 2 diabetes. And so whether that's through interventions in terms of access to food, whether that's built form, infrastructure design. Municipalities are really where people live their lives. It's probably one of the greatest areas where we can have the most impact on preventative medicine, and yet cities are often left out of the conversation when we're talking about health more generally. And so I think that's probably one of the gaps. But I mean, we signed on to the charter in November of 2021, and really the council decided to take action. So the credit due to the mayor and to city council, but the charter commits us to promoting, to tackling the socio and cultural factors behind diabetes, talking about integrating health into the decisions that we make, and we can talk a little bit more about that, engaging the community, and specifically those people who are most prone to diabetes and what their experiences are and what their needs are, and then of course forming partnerships. And as part of this, and I'll conclude in just a second, but as part of this, Novo Nordisk also capitalized the University of Toronto Mississauga for the Novo Nordisk Network for Healthy Populations to the tune of $20 million. And so earlier we were talking about data, your previous panelists. We don't have access to great data. We don't know where the pockets of diabetes are in our community. We have a rough idea. So working with this network, we're not only identifying where the hot spots are, but then we're also working with them to develop interventions that are community-led and community-generated that will hopefully have an impact.
Great. And you mentioned World Diabetes Day. It's also the 100th anniversary of the discovery of insulin, one of the greatest medical breakthroughs in history, and it was done right here at the University of Toronto at Connaught Labs. So I thought I'd mention that in passing. But I want to ask you, you're a municipality. Are you not in your lane? You know, people say, well, health is provincial, right? I hear these jurisdictional arguments all the time. Why is a city interested in this?
Well, I mean, we will stay in our lane, but as I said earlier, you know, we build cities. We build the infrastructure, which is trails and cycling lanes. We do that sometimes better than at other times. We build housing, and in terms of approving housing and what the density looks like. So if you come to Mississauga, it's a lot of single-family detached homes, but we are urbanizing and we are building up and we are creating denser communities. But we build those healthy communities. We also provide residents with over 200 different services, many of them recreation services, so how to get fit and to get active. We have parks, we have over 500 parks. Where do we put those and how are they programmed? So when I look at how cities are involved in this conversation, I think it's strange to me that cities haven't been involved in a conversation around health up to this point, when it's really been left to the federal and provincial governments to have this conversation, when in fact we are building the communities where people live. It's no secret that when you go to some of the great cities around the world, they're probably some of the most healthy. You know, you go to Amsterdam, you go to Copenhagen, what do they have in common? They're dense, they're walkable, they have a lot of public transit, they have trails, they have cycling, they have the things that keep people healthy. They're not car-centric. And so cities have all the power to help design communities. We should be part of the conversation about how we design them in a way that they're healthy for people. And so that it's not like you have to go and get a gym membership and you have to be deliberate about it, that your city is your gym in many senses, that you are able to get your 10,000 steps, that you are able to be active without a lot of extra effort, and that you don't have to rely on the car. And I say that coming from Mississauga, and I get that. And we are doing a lot of work around that. And I could talk about that for a long time, but I won't. But cities really do need to be part of the conversation.
And that brings us back to our earlier question from the audience about connecting that data, municipal, federal, provincial. Yeah. We need a better job of that. Andrew Bond, can you tell us a little bit about Inner City Health? Quite an amazing program, spitting distance from here also. Can you tell us a little bit about what you do and how do you integrate public-private partnerships?
Sure, thanks so much, Andre. So as a community-based organization, we work across Toronto, Greater Toronto area, to serve folks who are generally marginalized from within the existing public healthcare system. It's low income, racialized, homeless, newcomers and refugees, Indigenous communities, all those who are supposed to have access to the care that all of us have access to, but don't. And we know that there are deep access challenges right across the board. It is frightening that in a country that spends $344 billion a year on health, 40% of often provincial budgets, we still have 6.5 million people without primary care physician, 2.2 in Ontario. That is absurd that that actually exists right now. And we know that we can do better, but there is no way for us to be able to actually advance on this without actually looking at deep partnerships across public-private sector. We serve across 100 clinics. We've grown substantially from about 40 to 100 over the last 7 years, rapidly through the pandemic, of course, during the duress that we all experienced. But there is such a need for innovative models of care that actually respond to communities of need, that ensure that we deliver access. And we know that the one-size-fits-all model of public health care in Canada is not delivering. It's not fiscally sustainable, it's not operationally sustainable. Anybody who thinks that the only way that we are going to get through and meet the demands and the gaps that exist and this is only the visible gap, so we'll get to the invisible gap in a second, is by adding more of the same is, as we know, completely mistaken. There's no way we get from now to 6.5 million more people having just primary care access without completely changing who's at the table: cities, corporations, insurers, pharmacies, retailers, everybody who has an interest in healthcare. So the point of whose lane is healthcare, everybody's lane is healthcare. And so how do we ensure that we actually not only articulate what that is, what the lanes are, how we work together? We do that all the time in our work. We work closely because of the work that we do with housing sector, building infrastructure, all of we know that 70% of health is driven by, as you know, social determinants of health. The healthcare system that costs the huge $340 billion a year contributes 20% to healthcare. We're not orienting our systems appropriately. So cities coming on board, absolutely. Please not only be part of the conversation, but champion the conversations, convene the spaces. And so the most important thing for me isn't just the work that I do in the organization that I work at right now, but the convening practice of working together across all of the silos that have been created over the last, unfortunately, 50 years or so, that we now have the unfortunate obligation to break down and break down quickly, because we know that we're not in a sustainable place right now. The invisible gap, which I think is really critical, isn't just the 6.5 million folks who need to have access to primary care, all the gaps that are really in our face, but it's the missing absence, or the absence of shared value creation. It's what we could have been doing if we were working together across public and private systems, but we're not doing. And so we're only looking at the gaps that exist by virtue of what the standard is right now, but we're not looking at where we should be going. And so that gap is immense. And so to that point, what is the role of, you mentioned Apple Watches and digital, like building the digital and health infrastructure into every component of our life, as well as the access points. Every single access point that matters to a person should be an access point that we enable. How do we actually do that? And the most important and challenging part is, how do we then steward and convene them all together so that we're not doing not even a patchwork quilt, but 1,000 silos and point solutions, but actually integrate them. And partly CIHI and public organizations for interoperability are very critical, but the infrastructure to deliver that is private. And so how do we make sure that the digital highways that actually deliver the interoperability are actually being created, and that entrepreneurial need is met across the country, because the scale is huge. We know it's there, and so we have to deliver quickly. We're one small piece of that puzzle. In the work that we're doing, we're going very quickly. But all of us need to be thinking about exactly these pieces. What is my model now? How do I innovate on that to be able to think about the system of the future we need to be building towards, and to create those partnerships to be able to doing that? We know that, for example, housing is one of the most cross-cutting, which is why we do the work that we do, is one of the most powerful determinants of health. And there is a huge opportunity in the private space to work with public sector organizations and providers to come together to be actually deliver where we can actually change health outcomes, not just healthcare outcomes.
And give me an example of a private-public partnership that you're proud of at Inner City Health.
Sure. So we're starting from the very bottom, if you think about it, where we know that we have a system that is under deep duress right now. Clinicians are burning out. In certain provinces, 1/3 of physicians are looking to retire within the next 3 years. Administrative burden is immense. So we quickly adopted an AI technology, working with an electronic medical record vendor, to be able to do what's called AI scribing. If we get through today without talking about AI, we've missed the boat for sure. So we will say the words AI. So we have ambient scribe, so nobody has to touch a keyboard. We're able to then cut down our administrative burden by almost 20 hours a week per provider. That means not only more sustainability of the providers themselves, but also more ability to provide access and open up access, because you're not spending your time doing administrative things, and you're actually patient-facing, client-facing in the work that you do much more often. So that partnership was quick and early. We were one of the earliest adopters of AI scribing, despite working for folks who are homeless, newcomers, and refugees, while hospitals are trying to figure out, and no offense to our hospital colleagues, how to do this and when to go and how to follow Mayo or how to follow Mass General Brigham. We went there early because we know this is an easy win. We all have to be moving very quickly on those that are actually safe and effective.
And to give my own paper a plug, I did a column on AI scribing about 3 weeks ago, if people want to look it up. I don't think it's not in today's paper edition, but it is online. So we're going to come back to some of that stuff. Helen Siebel, welcome. Thanks for your patience. We're working our way down the line here. Now, BMO made quite a substantial donation to CAMH, the Center for Addiction and Mental Health, about $5 million. Why did you embrace a campaign like this called Leave No One Behind?
So thank you very much for the question and for including me in the panel today. So if we go, let's go back 2 centuries, because I'll start the answer there. So BMO is a 206-year-old bank, holds the first charter. And the first donation we made, the first corporate donation, one of the earliest ones in Canadian history, was to Montreal Hospital in 1835. And so we do have this sort of legacy and history of giving to support healthcare and different programs through the years. So if we sort of fast forward to maybe slightly more current time, over the past decade, we've given around $150 million to support various healthcare initiatives, with $23 million of that going towards mental health especially, and CAMH is a big part of that. Our relationship with CAMH started back in 1985, before it was CAMH, when it was still a variety of different organizations around Toronto. And we would support their programs and outreach into the local communities with funding. More recently, when the pandemic hit, we were working on a playbook for mental health in the workplace. As a large employer, of course, mental health and mental well-being of our employees is really important to us. So we had partnered with CAMH to explore how we can create this book together. And the playbook was published in 2020, and then a supplement, we developed a supplement focused on COVID-19. And I think that was the growth and evolution of a relationship with CAMH that helped us understand like what the need was within the community, within the mental health sector itself, and what we could do, what kind of resources we could apply to address it. So the playbook for business leaders has been downloaded over almost 9,000 times, and the supplement about 2,500 times. But then, we kept working closely with our partner, and that led to our support for the No One Left Behind, or Leave No One Behind campaign, which was launched earlier this year. So CAMH has, I don't know if anyone has visited, a beautiful campus that they are developing on Queen Street West. And that requires funding. I mean, it's not going to all come from government or from individual donors, although a lot of it does come from individual donors. So we gave the $5 million to support that campaign, and very specifically, the development of the Krembil Center for Neuroinformatics. So talking about technology as a key and important component to transform healthcare. And bringing world-class research in mental health here to Canada. So not only attracting world-class researchers, but then exporting that research out. I think a critical component will be understanding what we can do differently in the future to treat and care for these areas of disease, for the patients, for their families, for their caregivers. So our $5 million is going towards those things, and it's the result of a long partnership that we've had with them and lots of conversations, really.
And you don't just give money, you want a partnership. That's an important part. And why mental health? Because a lot of companies have shied away from mental health. So tackle those. What's the difference between a partnership and a donation?
Sure, of course. So let me start with why mental health. So mental health, I can't recall if we've heard the statistics here in the room yet, but mental health, 1 in 5 Canadians will have or experience a mental illness. And by the age of 40, I think the statistic is 1 in 2 will have a mental illness or will have experienced one in their lifetime. It's the single largest cause of disability in Canada, and it has a cost to society of more than $50 billion annually. It's a really, really big area that carries a lot of stigma, which has impacted how it's funded. I think it also creates about 11 to 15% of healthcare costs, but only about 7% of the healthcare budget, I believe, is spent directed towards it. So there's an unbalance there. I think more attention needs to be placed. There's also tons of comorbidities. So if you look at mental health and you look at other chronic diseases like diabetes, heart disease, cancer, they often go hand in hand. And so there's a need for us to address this head on. We have 50,000 employees across North America, and we'd be fools to think that none of them are touched by mental health issues in their families or as individuals. And we want them to be well. So I think for those reasons, we have tackled it head on, and by creating that playbook. I think partnership, when you're providing funding at that level, multi-million-dollar, I think that you have a responsibility as a company to understand the partner that you're working with. You want to share their principles. You want to understand that you're working together towards the same objective and outcome. Otherwise, it's just a check that you cut, and you may as well walk. You need to sort of develop that relationship. And what we found is that it unlocks other opportunities. We learn more about each other. Maybe they have a gap here that we could fill in some other way through other resources or relationships that we have as a large, multinational organization. So for that reason, it also helps us tell the story and bring others along. So there's a component of being in first with funding if we can be. It might actually encourage others to give who may have been reluctant to give. So if we come in as a sort of a big Canadian brand that is well recognized, it might encourage other companies to follow.
And we know there's good data now that it matters to employees where you invest your money, how that you reflect their values and their priorities. So that's mental health, obviously a big one. Robert, I want to continue on this about this theme of how do you forge a good partnership? And you work with a pharma company. That's not always an obvious partnership, a municipality and a pharma company. How do you make sure that works?
Yeah, it's a good question, and I actually really liked Andrew when you said healthcare is everybody's lane. I think I might steal that one. And what's interesting to me is when you look across Canada in a city level, we've often said that we're trying to build 21st century cities using 19th century tools. The way that powers are sort of outlined in the Constitution, cities don't really exist. And so that's probably a much bigger conversation around everything we do from healthcare to infrastructure and on down the line. But in terms of working with Novo Nordisk, Mississauga is home to the second largest life sciences cluster in Canada. Some of you may be familiar with Pill Hill, which is up in our northwest. And Novo Nordisk has been a very big partner in our life sciences sector, and they've worked closely with us. And so when they approached us and said, we want to do this, we would like the city to be part of this, it really was a bit of a no-brainer in that sense. And then what they brought to the table with the capitalization of UTM and the Network for Healthy Populations to help us access that data, to help us design those interventions so that it wasn't just on the city completely, I think really helped us. But in terms of structuring it, government sometimes shies away from partnering with the private sector. Sometimes we are a bit reticent about that. But in this term, we had a defined program that they had created, which was the Cities Changing Diabetes program. It already had 40 cities that have gone through it. And so what it meant for us was that we had a starting point. We weren't starting from scratch. We weren't trying to figure out how to start a diabetes strategy, who the partners were. They brought in that framework, and they brought in the expertise globally. And in fact, actually back in June, we went with them to Copenhagen for a master class in how to build thriving communities with Amsterdam and Istanbul and Madrid and Johannesburg, and had a week-long conversation around how we build communities. And what was great was we had conversations with cities that are around the globe that are still experiencing the same challenges that we're experiencing. And they opened up that network to us that we otherwise wouldn't have. So we were very careful when we structured it. We have a legal agreement. We figured out what our swim lanes are. I think that was a term used earlier. And we figured out where we can win and where they can win and what we're each responsible for. And once we've done that, it's actually been a great partnership. They've come to the table with funding to help us hire a community connector, something that we might not have done otherwise with tight municipal budgets. That person has been out in the community speaking with those groups that are most impacted by diabetes and coming up with, for the first time ever from a city perspective, what those interventions should be. What do they want to see? Is it education? Is it access to treatment? Is it more transit and trails and access to recreation programming? So, they helped do something that we may have done in the future, but weren't equipped to do at the time. But the crisis of diabetes is growing on a yearly basis, and so they helped us jump right in with 2 feet, and so far it's been a good partnership.
And you mentioned Copenhagen a couple of times, so I should just mention Novo Nordisk is a Danish multinational, and they very much bring their values to the table. Now, Andrew, you work with a whole bunch of partners at Inner City Health. How do you juggle that? How do you make sure somebody's nose isn't out of joint, that everybody gets their adequate attention?
That's a great question. So we have over 500 partnerships that are formalized through MOUs within just the City of Toronto proper to be able to do our work. That's what interdisciplinary, intersectoral work looks like. You can imagine there's a lot of paperwork, but there's also much more in the relationship building because that's where all the important things happen. I think you start from the perspective that someone's noise is always going to be out of joint. I think if you start from trying to prevent that from happening, you've already lost before you've started. It's how we actually try to work together and commit to working through the hard parts. That's the most important piece. There is no way in which we are going to manage public-private partnerships, nor the complex pieces that, as hearing here around Mississauga and Novo Nordisk coming together. These are very different spaces and cultures and traditions. However, that being said, we all have some very important reasons to have shared commitment and direction and vision. The question is, how do we align our capabilities to be able to create that shared value together? That does take something around relational contracting and this idea that's actually had backing by a Nobel economist around this idea of the most important value creation happens where you have the greatest barriers to getting there, and it's how you actually construct the relationship and the conditions of relationship to be able to get there, to be able to have those hard conversations just like we're having now. Probably 5 years ago, we probably wouldn't have been having this conversation together. So that means that we're getting somewhere. But it does take a lot of work in that relational work across very different spaces sometimes. But we cannot be shy to have those conversations. We can, with radical candor, have them. I think we've found and are increasingly finding that we're not quite so meek as a country as maybe we thought 10 years ago, 15 years ago around healthcare. And so, yes, it's hard work. It's some of the most important work. It couldn't be more important than right now, given the crisis in healthcare that we're seeing. And it's encouraging to see just how much companies from the private sector and the public sector are coming together to be able to try and figure out how to meet that need. We're just getting started.
And I think you're right. I think 5 years ago we talked about this in hushed tones. It was like, oh, he has a private partner. Okay. That kind of stuff. So it has changed. Helen, could you give us, the people in the audience, we have some corporate people, just some practical advice on why to do this? Maybe be Andrew's 501st partner or something. Why do this? What do they get out of it?
So I think that we have a responsibility to give back as companies. It is expected, as you mentioned. I think employees definitely vote with their feet when it comes to looking to work for a company that shares their own values. But we do get a lot out of it. We aren't necessarily experts in mental health or in any of the many different things that we support, but we find opportunities for our employees to volunteer. They can give back in those ways. That helps them feel more motivated. There's also a lot of our board members. We have a lot of employees who serve on boards, and that's a way to provide skills back to the nonprofits and charities that we support, and that gives them a different type of value than just the check that we're cutting or the partnership that we're developing. I think that you need structure. I think I heard a lot of people, both Andrew and Rob, you both talked about the importance of structure and upfront understanding each other. So you don't have to just give money away. Find the partners that fit with your organization, sit down with them, understand where you share a vision and where maybe you diverge as well. I love that phrase about finding, the greatest opportunity lies in the most complexity. And I think that there's definitely an opportunity for companies to get involved with that complexity, roll up their sleeves, but work in collaboration on these issues, because I think it's the only way we're going to solve them together.
Great. Now, if we have any audience questions, back here and then here.
This is for Robert. I know that in the world of pharmaceuticals, advertising is really hard, and there's a lot of governmental oversight on that. So I was curious, did you get any pushback being involved with a pharmaceutical company?
A little bit of pushback, not pushback, but some reticence from Peel Public Health, just because they, do have doctors, that obviously the Chief Medical Officer of Health. But in saying that, we've found a way to work through that partnership with UTM and with Trillium Health Partners as well. We didn't get a lot of other pushback for doing this, and I think it goes back to what we just talked about. We really set out the parameters at the outset that this is not so much working with Novo Nordisk, the company, as it is working with Cities Changing Diabetes, which is its entity in and of itself. And so that has helped us as well. So in terms of the funding agreements and that type of thing, we've really been upfront and open about it, and everybody seemed to be on the same page because, the end really, I don't want to say end justified the means, but we were really trying to get to a shared vision here and, a shared goal. And so we said, how are we going to get there? And I think it worked out okay. We haven't had any pushback so far.
And I think, Novo Nordisk, I know them fairly well, they're careful about this.
They are.
They don't flog their product, they never talk about it.
No, and they've been very careful. And in fact, the folks that we work with are part of Cities Changing Diabetes, and they do make that quite clear as well.
And, you don't have to promote insulin. Everybody desperately wants it or needs it. So,
yes.
There's another question here. And I don't know about you guys over there.
Thank you. Mr. Solomon's reference to GreenShield's model of the insurer being the provider reminded me of the old PSI in pre-Medicare days where Physicians Incorporated of Ontario provided the services to we patients and also provided the insurance, and that lasted for a few years before Medicare came in. And I don't know if they've examined that PSI model. But my question particularly, or my reference is to Robert's comments about Mississauga and the city taking the initiative in this, and I believe this totally. The city is a community and is a home, and in April of this year, 2023, the city of Stratford, which is down in southwestern Ontario, passed a motion as city council that it would push for leadership in home care services and push through the Ontario Municipal Association in trying to have money transferred out of long-term care per se and more emphasis on home care, and very much realizing the city's responsibility in this area. And if I may editorial add from the government's own financial regulatory reports for this year, the amount of money that goes into home care is $36 a day from we, the taxpayers, versus $170 from a long-term care bed and $750 for a hospital bed. Those are the averages. And that money is projected to stay the same for home care for the next 3 years. And so I say that because the city of Stratford is trying to say that whole foundation of healthcare begins in the home, with the Ontario Caregivers Association predicting it's 86% of healthcare. Thank you.
Right. So we'll take that as a comment and maybe an invitation that this is a good area to invest in. Elder care needs a lot of work. So we have time we'll squeeze in one last question. I see Dr. Scully has his hand up just over here.
Thank you, Andre. Very interesting panel. Congratulations in addressing a difficult issue. And as was pointed out, now we can do it. 10 years ago, we couldn't. I've always been a great proponent of public pay for necessary services. That said, I believe strongly in private-public partnerships in where we go, and it doesn't have to cost a great deal of money. There's a relationship between the Canadian Concussion Centre and LIUNA, one of the biggest unions in the country, on providing money for people to do a seminar program every other week on concussion, what it means, how to get back to work, what the problems are. Started in Ontario, is now across Canada and North America and Western Europe. It's been tremendous. The cost for that was $300,000, and I'm about to help renew that contract. On the other hand, the Peter Munk Center at the University Health Network has invested $1.5 billion with the divisions of cardiac surgery, cardiology, and vascular surgery, and that's a strong partnership. My question to all three in the panel, if you build responsibility, accountability into this effort, it works beautifully.
I think they would all say yes to that. So,
yeah.
Thank you, Dr. Scully, for some really good examples of private-public partnerships. Unfortunately, we're out of time, so please join me in thanking Robert Troartha, Helen Siebel, and Dr. Andrew Baum.
My name is Carly Weeks. I'm a health reporter with the Globe and Mail, and I'm going to be leading you through the sort of afternoon part of this session, closing this out with some really exciting content and discussion, as I'm really looking forward to getting to. So before we do that, we're just off the top going to watch a very brief video from today's sponsor.
I'm here today to share my story because I'm very grateful. I bought my medications out of pocket. Everybody knows it's difficult to do that. It's expensive, but you do what you have to do. It's not a good feeling. I wish I can describe it to you, but I can't. It's just stuff that you need, medications that you need.
I love seeing the change in people when you are able to provide them with sometimes simple things. And I feel like the essential medicine is meeting a basic need. It's a prescription, and we forget how important and how much of an impact that can make on someone's lives of being able to take an antibiotic when I'm sick or take those diabetes medications when I need them.
When I was approved, I got a phone call saying that, yes, I'm qualified for the program. And I wish that Emma, the lady that called me, had seen me. I told her that you really had me dancing, and I usually don't dance. Nobody get me to dance. So yes, I was excited. Yes, I was very happy.
Everyone's human, everyone's got things going on in their lives, so it's just nice to be able to offer something to help individuals, in this particular case, the essential medicine program and medication coverage and prescription coverage, to be well.
I did it, and it's working for me because nobody needs to go without medications.
And now to say a few words, I'd like to welcome to the stage Harriet Ekperijan, Vice President of Mental Health with GreenShield Health.
Thank you, Carly. A loaf of bread, a bag of milk, and a pound of ground beef. For many of us in the audience today, these are merely items on a grocery list. But for many Canadian women, this represents so much more. 71% of women have said that the inflation is impacting their mental health. We know that food prices have increased at least 9% over the last year. My name is Harriet Ekperijan, and I am the Vice President of Mental Health at GreenShield. For most of my career, I have focused on increasing access to mental health services for people across Canada. One of the areas that I have been fortunate enough to lead at CAMH in my earlier career is improving access to intake. I helped many women at a provincial level, but I really craved doing this at a macro level, and this is why I joined GreenShield. GreenShield, as you heard, is on a quest to become Canada's first payer and provider of health services. As you heard from our CEO, Zahid, we started in 1957 with a quest with the view of being not-for-profit services. Until this day, we continue on that mission. I joined GreenShield as it started to work on its health services. I have the privilege of building our mental health services, ensuring that all Canadians have access to the mental health support when they need it. We know that mental health affects all genders, but we know as well that women have been really impacted as a result of the pandemic. During the pandemic, 500,000 women left the workforce because they had to be home to care for their loved ones. And as a result of the pandemic, and continuing until now, women continue to struggle with high levels of anxiety and depression. We know that a lot of women are trying to get back to the workforce, but with inflation, this is not easy. And what we're hearing from the Mental Health Research Canada is that although more women than men are likely to seek help, more women, at least 66%, state that the help that they receive is inadequate. When we layer on marginalized and underserved population, we know that the results are even more grave. 32% of women from the LGBTQ+ communities and 17% of women from racialized and underprivileged communities report that the help that they receive is inadequate. And this is compared to the general public. When we look at the financial status of women, we know that more women earn less than men. And women are saying that they're not receiving help that they need because of financial barriers. And these are the reasons why GreenShield decided to focus its social impact on providing mental health services for women. Diving deeper, we can see that not all women struggle the same. We know that societal norms and pressures placed on women play a huge role in their mental health. Many mothers are navigating new challenges in the workforce as they try to get back to the office and seek help for their children. Childcare waitlists are at an all-time high, with many cities having 2 to 3 years of waitlist. And these are all impacting women's ability to return to work, ability to find a place for themselves, and ability to seek the help that they need. Now that we have uncovered some of the societal pressures that prevent women from seeking help or from providing the help that they need adequately, we're all here today to unpack and discuss what we can do to provide women with the support that they need. 3 years ago, I received a phone call on my cell phone from a patient that I last saw in 2004. She called me because she was struggling to find the right therapist for herself. She had seen several therapists, but constantly found that she was not finding the right match. When she approached the care coordinator of the health services place that she was receiving service for, she was told that she had to go and find her own therapist. That is unacceptable. One of the reasons why women are saying that the support that they're receiving is not adequate is because of the lack of matching. According to the American Psychological Association, finding the right therapist is a key success factor for successful recovery from depression and anxiety. One of the reasons why I believe that this patient and I had a connection is because we shared many similar backgrounds. Like me, she was an immigrant to Canada. Like me, she was raised by a single mother. And like me, we faced a lot of challenges, and I was able to relate to her. In the general public system, you get what you get, and you don't get upset. You get the next available therapist, and when you don't have a match, the blame is put on you, and you're asked to go and find yourself somebody else. That, again, is unacceptable. How can we move and fix this? Today, we're collectively having discussions, trying to move the barriers that prevent women from seeking the help and getting the help that they need. I believe that what GreenShield is doing with our women's mental health program, GreenShield Cares About Women's Mental Health, is fundamental, and I would urge many of us here today who are either healthcare professionals or work in organizations to follow the lead. Matching is at the heart of what we do. We ensure that we have over 50 factors that match a client to the right therapist, and this includes religion, background, cultural sensitivities, amongst many others. The time of being provided the next available therapist is over because we are not doing the right thing for women. So that bread, that bag of milk, that pound of beef, as we gather here today to discuss the gaps that we face in healthcare, as we gather here today to try to move the barriers, these conversations may not reduce inflation, but what it will do when women are faced with these issues that increase levels of anxiety and depression at an all-time high, we can ensure that the right services are in place to help to get women back on their feet. Miigwech, and thank you.
Thank you so much for those remarks. I think that's a really good jumping off point to the discussion that we're about to have. We're here today discussing public-private partnerships, which is a controversial topic in Canada. I think we can all agree that the status quo is no longer working in our healthcare system. But as a health reporter who gets the chance to speak to providers all the time, I'm consistently amazed at the work that's being done across the country to try and better the system. So that's kind of what we're going to be talking about in this next panel. So I'm going to introduce all of our panelists, and we'll get started. First, I would like to introduce Dr. Sonika Singhal, Assistant Professor and Graduate Program Director of Dental Public Health at the University of Toronto. Next, there is Jen Quinlan, the CEO of the Flemington Health Centre. We're also on the panel Dr. Mariam Abdurrahman, Chief of Psychiatry at St. Joseph's Health Centre, which is part of Unity Health Toronto. And of course, rounding out our panel, we have Tom McNeil, a retired medical social worker with Nova Scotia Health. So welcome everyone to the stage. So before we get started on the questions to you, I have a question for the audience. And so this is the poll that I think you had already done before. The QR codes are on your badges. So if you want to answer the poll question, you can scan the QR code at home. I believe there's prompts for you on the screen. So this question can be a bit of a loaded one, but do you feel that the private sector can play a greater role in addressing healthcare disparities for underserved communities in Canada? So we have a lot of people saying yes. I think that the room is a little biased in that direction, which is fine. So that's great. And I think that, as we look at some of the challenges our healthcare system has faced in the last almost 4 years since the pandemic began, cannot believe it's been almost 4 years, we need to talk more about some of the solutions. So Sonika, I'll start with you. You've dedicated a lot of your career, and I think everyone here has, to kind of working with communities that are underserved, that need better attention. And that's been, if one thing came out of the pandemic, maybe a silver lining, is that we're having some of those tough conversations, I think, in a bigger way than ever. I was wondering if you could highlight some of the work that you've done around dental care, trying to work with equity-deserving communities, and some of the challenges that remain. Big question, I realize. You have like 1 minute.
Okay, sure. Hello, everyone, and thank you for inviting me to contribute to this panel. I think this is a great initiative, so thanks very much. Overall, I think over the years, I've been working as a dentist for more than 25 years and as a dental public health specialist for now almost 12 years. So I've got opportunities to work with a lot of populations, vulnerable populations. I did my dentistry actually in India, where I worked in public hospitals, and we were doing more than 50 cases every day. And that was a publicly funded office, which is no cost dental care. So a lot of work has been done, and I have worked in private setups as well, where people can afford care, ortho treatment, implants, and best of care. So a lot of disparity I have seen, but a lot of experience in that field before I talk about the program itself. Yeah.
Tell us, while we're with you, tell us a bit about the program and sort of what needs you're filling.
Okay. So right now we are conducting a One Smile research program, which is being run by Dental Public Health discipline of the Faculty of Dentistry, University of Toronto. And the purpose of this program is twofold. So one is to provide comprehensive dental care, which can be provided by any general dental office without any cost to people who are not able to afford dental care in the last 2 years. So that's the first purpose. And second is the research part, because we need sustainable solutions. This is a one-time program. So we are taking this as an opportunity to actually recruit a lot of participants, more than 500 as the number, and we are providing them care over the years to show that dental care is not only supporting them in improving their oral health, but maintaining oral health. And what is the impact of that dental care on individual level, family level? Apart from that, the importance of that dental care and the impact from the societal level and healthcare system level. So we want to build that database as well. That's the idea. And I would like to just add one more thing here, that this program is unique, especially in Canada, because we say that in Canada, dental care is not about meeting dental needs. So people's dental needs is actually not dictating what treatment people will receive. It's about their insurance or their ability to pay, which dictates what treatment they receive. But here in this program, the treatment needs are met based on what people really need. So that discussion happens between the dentist and the patient. A dental plan is developed, together, and then the treatment is need, taking the cost aside.
Thank you so much for that. And I know there's been so much attention focused in recent months on the universal dental program, and I think anxiously awaiting to see more detail on that any day now, we hear.
Yep.
Jen, I'll turn to you. Obviously, in the pandemic, the area of the Flemington Health Centre was one of the epicenters for COVID-19 in Toronto, but really that's an area of the city that has been facing challenges for decades. And I'm wondering if you can just tell me about some of one of the programs that was developed out of the pandemic or during the pandemic that really kind of helped recognize and bring greater treatment to people in that area who've been, so underserved for so long.
Sure. Thanks so much, everyone, for having me today. My name is Jen Quinlan. As Carly said, I work for Flemington Health Centre. We're a team-based primary care organization, a nonprofit that serves folks in the Flemington Park, Thorncliffe Park, and Fairview neighborhoods. So for those of you who live in Toronto, you may be familiar with those neighborhoods, but maybe not as in-depth as some you would like to be. For example, you might go to the Costco, you might go to the Science Center, you might go to the Aga Khan. But for me, those neighborhoods are about the great Afghan cuisine, they're about the neighbors that care for each other, and they're about the folks that drive our taxis, fill out our gas, are able to keep our city running. So during the pandemic, I think we all had huge gratitude towards those folks. There was pots banging, there was lights lit, and I would say, unfortunately, I don't feel that gratitude anymore, and I'm hoping that conversations like today can be some of the ones that reignite that gratitude. The folks of Thorncliffe, Flemington, and Fairview neighborhoods are primarily newcomers, new to Canada. Right now, we have a large influx of Afghan refugees, so for folks who are paying attention to the demographics of the city, that is a newer influx in our neighborhoods. At one point, sort of at the tail end of the pandemic, we had almost 400 Afghan families waiting for team-based primary care, just in that small part of the city, so a big need. We're able to meet what we can meet, but hopefully with innovative conversations today, more can be done. During the pandemic, Carly, to your question about what worked and what could we build on, one of the things we're the most proud of was our program called East Effort, which is a community health ambassador program. So earlier in the panel today and earlier in the conversation today, people talked a lot about leveraging technology, leveraging ways in which people can stay connected. In the neighborhoods that I work in, the ways we do that is through people power, through pounding the pavement, through going into buildings, through going door to door, and making sure that neighbors take care of neighbors and folks are well connected. So Flemington Health Centre, in partnership with a number of different organizations, hired 35 local experts. So people that lived in the neighborhood, that maybe were informal caregivers, maybe they ran a babysitting program, things like that. And those were the people that helped us convince everyone to get vaccinated. Those are the people that were trusted. Those are the people that said once they got vaccinated, they could bring 4 more people, 10 more people. Those were the folks that spoke languages, helped without when folks didn't have OHIP. So all of these types of barriers were addressed through people and through connections, and not even a huge amount of people. You know, if you think 35 people that got over 16,000 people vaccinated in neighborhoods that really needed that care. So we're looking forward to expanding that program and continuing it.
That's really exciting. I mean, one of the things that we know about vaccination is that you really need to have trust and to build that confidence. And so these community ambassador programs, like the one you're mentioning, have been hugely successful in actually buying in, you know, people who are in the community can, you know, sort of giving good information. It's not just convincing people to get vaccinated, it's giving them the right information at the right time, right? And if you aren't familiar with the, you know, the model of community health centers, they're a very unique model in Ontario. I recently had the chance to do a story on some of the work they're doing. I would encourage all of you to look at some of the things that they're doing, everything from like primary care to like helping people get connected with, you know, people to help do their taxes. Like it's quite an amazing enterprise that's been set up that is already functioning in Ontario. Miriam, I'll turn to you now, and Tom, you're up next. But just putting you on notice. I was wondering if you can tell me a little bit about the mental health program that you're involved with in Toronto, and sort of how the partnership model has helped build on its success.
So good afternoon, everyone. Thank you so much for having me here. It's a really exciting time to talk about public-private partnerships, particularly in the context of mental health. And I'm just going to go back to a couple of things that were said earlier, because basically the youth program I'm going to talk about actually ties in with community health centers. They're one of our partners, and there are a lot of, as Sonika was saying earlier, we talk about dental needs. They're actually health needs because they also affect your mental health. They affect the way you evaluate yourself. You need wraparound care, and community health centers are one of the places that deliver that level of care. So I'm the chief of psychiatry at St. Joe's Health Center, and very recently in 2022, we opened an inpatient unit dedicated to transitional age youth, which really it captures the 19 to 26-year-olds. We've recognized that there's growing needs in this demographic for years and years. I mean, the government has the data. We recognize this. The pandemic accelerated things, right? And the reason we're able to actually address this gap was through very generous, donors on the private side. And so we now have the Royal Bank Canada short-stay transitional age youth unit. It's an inpatient unit, 6 beds. It's the first of its kind in the city. And this collaboration has made things possible in terms of capturing that very vulnerable age group. Because what happens is, right up until you're 18 years and 11 months, you have this village dedicated to your care. There's every level of need is met. Suddenly you're 19 years old and one day, and it's goodbye, you're in the adult system. Very fractured, difficult to navigate, and just really, really difficult to engage young adults who don't necessarily rate, mental health as being sexy or being anything they need, because they're invincible, they're young, and what do they need to worry about? Well, we recognize that things happening at this stage can actually have very significant long-term implications, and so we want to capture needs at this stage. In opening up the inpatient unit, we've been able to target clinicians who are trained in this particular age group with very specific skills to actually address early presentations of mental illness, be they anxiety, be they psychosis, be they depression. What we've seen during the context of the pandemic is a lot of social anxiety, a lot of, regression in terms of the natural milestones. So whether it's making friends, whether it's attending school, whether it's getting a job. And so through this inpatient program, we're able to deliver services targeted at this age group. What we found, though, was we have an uphill battle. What do we do for them when they're discharged? Where do they go? Because we don't have an outpatient program dedicated to that particular age group. And in the new year, we will have something for that age group, but it's specifically for early onset psychosis. And this has only been made possible through a very generous donation by the Slate Family Foundation. Mm-hmm. So it'll be an early onset psychosis program that also co-treats substance use, because we recognize increased rates in this age group. And so through this public-private partnership, we've been able to address the needs of 19 to 26-year-olds, going from the ED when they get in, through the inpatients, through back into the community, because our goal is to have people thrive in the community. We're going to make this possible through our partnership with the Lamb Community Health Center. It's a community health center in the West End that delivers multiple programs and services and is adept at actually addressing a number of these needs related to health equity. So it's a really exciting time for us in terms of the level of private partnerships with very interested donors. I mean, if we waited until the government decided to fund things, we'd be waiting for a really long time. And while they continue to underfund mental health, we continue to see this growing need, and we're not meeting our patients' needs. And so it's a very exciting time for us.
Thank you so much for that. I mean, it has been such a huge challenge, seeing what's going on in terms of the unmet needs when we're talking about mental health, particularly youth mental health. And I think it's something that's been touching so many of us. And I think it's really it's great to hear about programs like that are getting some attention. I know that once upon a time, donors wouldn't even want to attach their names to programs like that. So it's quite nice to see. It's a different world today. Tom, I was hoping that you could just shed a little bit of light on the program that you founded that is basically a lifeline, financial lifeline for people who are dealing with cancer. We may not think about the financial strain that comes along with it. Tell us about what you've done in Nova Scotia.
Yeah, just in general, I think it's good. Thanks for inviting me. Health affects wealth, and wealth affects health sort of idea, right? But when I first started working at the Cancer Center, I've noticed that you were thinking it was going to be a lot of emotional concerns being brought forth in a cancer center as a social worker, and there was, for sure. But many things evolved around access to medications at that time, the early days. But then it became, well, it wasn't only medications, it was lodging, it was transportation, it was dental prior to treatments, hospital, things for home with discharges, hospital beds, specialized mattresses, customized wheelchairs. So the fund became designed to help with that financial impact that people were facing when they became ill with cancer. But in addition to that, in addition to helping with those practical needs that the cancer brought forward, it also became recognized that you lose your income when you get sick, right? And so the fund started to help with mortgage payments and fuel and electrical bills, phone bills even. Sure. So the cost of daily living became affected as well, like the perfect storm becomes created. You have more bills, but you have less income. So the fund started in 2005, and that's the things it tries to address.
Give me some of the numbers. I mean, it's pretty impressive. How many millions of dollars have you given to pay? Has this fund given to patients since then?
It's, actually, I just checked before coming, of course, but 4.6 million. And donated primarily through the community. It's not government funded. Businesses do fund it. And it's run through the Cape Breton Regional Hospital Foundation. And it meets the practical needs of people when they need it.
It's just one of those things you don't immediately think about, but to be able to give that amount of money out is just lifting that weight from people at one of the most difficult moments of their lives. Is very important. And I think that's a really great example, and we've touched on several of them of how sort of the idea of partnerships can help bridge some of these gaps. I'll throw this one out to the group, so whoever wants to jump first. But how we can, we look at all of the problems in our system, and we say, it looks like a bit of a mess at times. But there's also like some really, I think, great ways we can actually start to tackle some of these continuing inequities, how we better address some of the disparities in health. And I'm wondering, if you're thinking, sort of looking toward the future, what are some of the things you hope in your area of practice to do more in? What do you think we can realistically achieve in the short term as we sort of wait for some magical overhaul that will fix all of our healthcare problems?
Maybe I can start with dental care.
Please, start with dental care.
Yeah, so I'm going to say, I think we all can appreciate how oral health is integral to overall health, as Miriam talked about it, Tom talked about it. So it's been recognized that oral health we cannot see in isolation. It's so much impacting other health issues, and overall, in itself, if somebody is not having the best of oral health, it's mentally disturbing, it impacts your self-esteem, it impacts your employability. So a lot of aspects are related to oral health. And as we all know, and actually I'm very glad that initially Kathleen from Kai talked about the oral problems and how children are going to day surgeries for under GA. Actually, 1/3 of all the day surgeries for children in Canada are for dental problems. That's a huge number. And that's all preventable. So that's the most important thing, that this is not that genetically or hereditary or because this had to happen, it could be avoided. So yes, there are a lot of gaps, inequities in the system. And then as a lot of data, whether it's Canadian Health Measure Survey or CCHS, Canadian Community Health Surveys, which show that 1 in 5 Canadians cannot afford dental care. But then the stats are further severe when we dive deeper, that people of high income are having insurance. It's actually 1 in 10, and people who do not have insurance or are low income is 1 in 3. So those gaps need to be filled. And I will say there are public programs. It's not that there are no public programs. In all the provinces, in territories, there are some public programs out there for children or people with disabilities or for seniors or people on social assistance, something. But it's all like a patchwork everywhere. So I think that's the bigger problem. And the income eligibility criteria which they choose is, like in Ontario, there is a Healthy Smiles Ontario program, I don't know how many of you know, for children from low-income families. But then the low-income family is $25,000. That's too low. There are so many people who are earning above $25,000 and they still are not able to afford dental care. What about them? So I think from the federal perspective, it's a very good initiative which they are coming up with that the CDCP, Canadian Dental Care Plan. And the income eligibility is up to $90,000, where people or families earning less than $70,000, everything would be covered for dental care. And above that, there should be some co-payment from the families between $70,000 to $90,000. But again, this program still has to roll out, and there would be some gaps there. Like meanwhile, as I was talking about our One Smile research program, for the last 2 years, we have been running this study, and we're trying to collect that data to show that where are the gaps and where it needs to be addressed. I really expect that in the future, when the Canadian Dental Care Plan will be rolled out, I really think it's a great step in the right direction, but there would still be some gaps which our program like this public-private partnership which is happening would be able to address and can show further that what can be done so that ultimately, maybe not 100%, but we are able to fill as much gaps as possible.
Thank you so much for that. And I'm glad you touched on the dental program because I wanted to ask you about that, so thanks. Who else wants to jump in?
I think it's something we forget sometimes, that even though we talk on the macro level, it's an individual that's coming forward, or a family, with an illness of some sort, health issue. And even if we address, and we need to, some of the bigger things, but I think on the local health care, like at a hospital level, it's not just about providing surgery or chemotherapy or that sort of thing. We also have to recognize this financial impact, because people can't access these things if they don't have the money. So I think even on the ground level, there needs to be more recognition of the financial impact of a treatment you're proposing. And I think we got to be contextualize that whatever we have to have that flexibility, I think is the word I'm looking for, that you're able to address that individual need of the person in front of you. If it's somebody needs $2,000, but well, we only do $150, it sort of doesn't, or I need a wheelchair, but I only do medication. You need that control and autonomy there that gets the job done quickly.
Yeah, that makes a lot of sense to me as well. From my experience, I would say 2 things that are jumping out are sort of reframing what is within this space of healthcare. You said wealth is health and health dictates wealth, and that really spoke to me a lot. So, thinking about, we've talked about the social determinants of health. I've heard it also reframed as the moral determinants of health. So if we, as folks in this room, want Torontonians and Ontarians to be healthier, looking at income, looking at loneliness, looking at pieces like that, and having that be part of our job. part of what you were speaking about also sparks the idea of social prescribing. Maybe something we can touch on a little bit too is, a lot of folks really take what their pharmacist or nurse practitioner or best friend who's a lab tech say very seriously. But the idea of prescribing something that's not a medication is also something we could consider as a quick solution and that governments could fund. So, in your case, there'd be a $2,000 prescription for support for that mattress, and then that's filled. So
the problem is solved.
Yeah, the problem is solved. We have to find $2,000 somewhere, but it sounds like you've come up with a solution, so we'll just replicate that. But I think that the idea of the moral determinants of health and some of these programs that we're learning from outside of Toronto and Ontario that we could replicate also speak to me a bit. I don't know about you, Mary. But.
No, I agree. I mean, I think what we're all talking about in various ways would be structural determinants of health. So we know that the way that our structures are organized right now are not ideal. We have many silos operating, multiple expenditures for the same thing, and a lot of waste of resources. But I think this also goes back to a very fundamental problem, right? So what do we value as being worthy of a long-term investment? And so in thinking about mental health as an example, it's never been sexy, and as Carla mentioned earlier, a lot of donors wouldn't necessarily have attached their name to it. So now people are funding it, but we still have this fundamental problem where, as a society, perhaps we don't value it enough. We don't understand that pacemaker that costs so much money, that cancer treatment that's going to cost so much money, can actually be diverted if we invest right in mental health from the get-go, because the ability to follow through on your treatment recommendations, so attend the heart function clinic, is all dependent on having that, that capacity mentally, but also in terms of your social circumstances. So we're talking a lot about social adversity, we're talking a lot about social prescribing, and I mean, from the perspective of the government, perhaps it looks like people are being cared for because there's ODSP, but ODSP does not allow you to afford regular dental care. It does not mean you can afford the right level of, optical care that you need, or that you can afford the treatment required for your mental health. A lot of people are aware that there's a new treatment called repetitive transcranial magnetic stimulation, or RTMS, and a lot assume it's free. It's not actually free. We know that the remission rate from depression is as high as 30% when you have treatment-resistant depression. We know that the response rate is as high as 50%, yet it is not actually free because OHIP does not fund it. Rather, if you have a hospital where the hospital and or a donor has purchased the machine and you have technicians, then it is free because we do not charge people to access these services. The fundamental problem, though, goes back to everything we've said, which is, well, what are we valuing? And are we looking at things as a long-term investment as opposed to, here's $2,000 that you need now. Why do you need that $2,000 now? What did we fail to do, earlier on?
It's kind of really reorienting things to work for the patient, right? I mean, I think that's kind of what we're talking about, and you guys are all, it seems, working in areas in really kind of innovative ways to try and deliver better outcomes for people. And one of the issues that I thought we could touch on briefly is that of time lags and delays. Because that's one item that is just so difficult to get around. I mean, if you need to see a primary care provider, you don't have access to one, you're at the emergency room, and there's so many different I think barriers and access there. And I'm just wondering, if we can sort of briefly just touch on, and I realize that we're not sort of talking necessarily in the context of a hospital or an emergency room, but just some different ways that you guys are working to try and help deliver or bring care to people in the community where they are when they need it. I mean, Jen and Mary, you might be best off to start this part of the discussion, but just kind of that idea of helping connect people to care in a timely way. That's really such a tricky thing for so many, right?
Sure.
Yeah. I mean, one thing that we've realized over the years is that a lot of our patients that fall through the cracks do so because we don't really have mental health care navigators. And so as part of the new outpatient piece, our young adult program starting in the new year, one of the things that we embedded in the program is a care navigator, because we realize that as you age out of the pediatric system and attempt to reach the adult system, there are a lot of hoops to jump, there are a lot of tasks to be completed, and you need a navigator to help you get through this. So I think the nimbleness of giving people the care that they need, meeting them where they're at, and following them through needs some level of system navigation. So if you're a patient with cancer and you go through cancer, because of the way Cancer Care Ontario is set up, you have very well coordinated care. There's barely any waits. There's, resources at your fingertips. We don't have anything like that in any of the systems we've just talked about. So I think we need to think about having navigators and having care coordination. Otherwise, people continue to fall through the cracks.
Yeah, and I would add to that, I think it's about redefining the team, maybe. When we're talking about the healthcare crisis, we often talk about shortage of specific clinicians, whether that be physicians, nurse practitioners, nurses, and that's a huge problem. But those folks can work to their full scope if there's the team, the navigator, the community health ambassador. I would also say, we learned a lot during the pandemic about the proactive nature of reaching out to folks. So, doing friendly calls, seeing how people are. That way, you're preventing the downstream effects or the hospitalization. Community health centers tend to care for very vulnerable folks. So, for example, Flemington Health Centre cares for a population that is 57% more complex than the average Ontarian, yet our clients access emergency department less than expected. So that balance of the team, of the availability, of 24/7 on call, evenings and weekend care, those types of things are, I think, what really help folks in their need, in the moment of need, rather than sort of adding additional things maybe during the day or only having virtual options. It's a complex way of bringing different services together.
It's funny because for dental care, it's very tricky because healthcare in Canada is publicly funded, but not dental care. So if there are any dental emergencies and people who cannot go to a dentist because of affordability, they will land up in a physician office or our hospital ER, which is ineffective and inefficient because there are no dentists out there. So if a physician is treating a dental emergency, what they can do, they can just refer them to a dentist or prescribe a medication, an antibiotic or an analgesics, which is of no use because you need to treat that problem. So it becomes tricky, and at the same time, it's a double negative thing that you're not being treated. Ultimately, funds are being released, like healthcare system funding is being done for that consultation, and then you're taking somebody's spot where some other person can be treated for other health condition which could be served in a better way, effectively. So it's just negative, and nobody's being helped.
Thank you for that. Well, we'll have to leave the discussion there, and I just really appreciate all of you bringing your very unique perspectives. I think really kind of inspiring examples too of ways the system can work better just without having, to reinvent everything. So thank you so much for that. And before we move on to the next speaker, we have one more poll question. This one's multiple choice. So in your opinion, what's the best way for businesses to support access to healthcare for underserved communities? So corporate giving, expertise and resources, raising awareness, research and innovation, and other. And I think we've heard some, kind of neat examples of different ways that that's working across the board right now. Of course, I think we'd all like to see a healthcare system that's fully funded to the needs that meet everyone's needs when and where they are. That may not be super realistic, but we can always hope for that. But in the meantime, it's been really great to hear about ways that you all are kind of working to change the system and make people's lives better. So thank you so much for that, Sonika, Jen, Miriam, and Tom. Thank you for your time today and being here. Yeah. And now it is my pleasure to introduce our closing keynote for the event, Michael Landsberg. You're probably familiar with the name and the personality. And he is a mental health advocate and founder of the Sick Not Weak Charitable Foundation. He probably has been, for a long time, best known as the host of the talk show Off the Record, which was broadcast daily for 18 years. It became the longest running daily talk show in Canadian history. In 2009, Michael shared publicly his then decade-long struggle with severe depression and anxiety. And since then, he has become one of the country's leading and best voices, pushing Canadians to see mental health and illness as a sickness, not a weakness. Michael, welcome to the stage.
Thank you. Hey, folks. How you doing? That's not my normal voice, just so you know. I wanted to read to you something before I started because I take what I do really seriously, and I want you to understand that I have limitations, right? So here's my warning, kind of the disclaimer that you would see before a TV show. Warning, The following talk will contain raw, emotional, and personal content and depictions of mental illness that some might find triggering. Viewer discretion is not advised because this speaker believes this is what we all need to hear, and he's frustrated by the clinical, dull, and impersonal ways mental illness is often portrayed. Further, the speaker is not qualified as a medical professional of any kind. Be aware, as he has proved for years on television, he talks like he knows everything. He does not. Viewer discretion is advised. So now that we have got that out of the way, hi, my name is Michael Landsberg, and I'm, as always, I can say that when I am talking about mental illness, that it's the single best experience of my life. And I got to do these amazing things in my television career. I got to host this cool show where I got to meet all kinds of people. I got to, not that like I'm boasting, look what I did, but I got to host the Olympics on CTV. How cool is that? But not nearly as cool, for real, as standing here in front of you today. And as an added bonus, standing in front of you here today as a member of the GreenShield team. Because I approached GreenShield about a year ago, which I'll tell you in a second, and I thought personally that Zahed, the CEO, would be here for the start of my talk, but apparently, so I wanted to tie this into filling the gap. My role, I kind of see it, filling the gap, is to fill the gap between the way mental illness is perceived and the way mental illness is in reality. Because I think the gap between those two things, I think that's the stigma. The perception of what mental illness is as opposed to what it really is, that's where the stigma is. And if you haven't been through it, if you haven't experienced it, you can't possibly know what it feels like. And you need people like me, like Erica M., like Corey Hirsch, who's here with us today, talking about what the experience of mental illness is like. So that's the gap that I try to fill all the time. And for a couple of moments today that I have with you, I'll try to do so. I kind of look like the stigma began in 2011 with the first Bell Let's Talk Day. When I say the stigma, the anti-stigma time. I kind of feel like that was the kickoff in this country where we talk all the time about the stigma. We all go to events, we all read things about the anti-stigma, kill the stigma, beat the stigma, stop the stigma. But here we are in 2023, and the stigma is still alive. And the stigma is still alive and making us unwell. I was going to say it's alive and well, but it's making us unwell. And I'm trying to figure out, as I have every day for the past 14 years, how we can best make a difference, an appreciable difference in the stigma. And I thought to myself, okay, why have we failed? And I have two theories on, there goes my voice again. I have my bar mitzvahs next week. I have a couple of ideas on that. Number one, I think we have failed because we haven't made it personal enough. And let's stick with that. That the message has come in a way that's too clinical, too serious all the time, too dull, too everything like that. Everything has been so serious and people don't pay attention. Hey, I worked at Bell Media. I had to watch videos that were directed at employees of Bell Media, the leaders in mental health talk, and these videos that we had to watch were torturous. I talked to my friends there, not one of them thought that this was useful because it's so sanitized, it's so corporatized. And I had this idea that I wanted to come to the world with, but I came to GreenShield with, because I thought, okay, there's got to be someone out there who sees this the same way that I see this. So the stigma to me is still a problem. And I'm going to prove to you, yes, I'm going to prove to you right now that the stigma is still an issue. Here's how I'm going to do it. My name is Michael Landsberg. I battle an illness called depression and anxiety. I'm on medication today. I was yesterday. I will be the rest of my life. I understand why people take their own lives. I have a tattoo on my arm commemorating the lowest point for me, 11/24/08 YULMH 5210400. I'm not going to explain what it is. You're going to have to figure it out yourself. And I find that by sharing what I'm sharing now, well, let me finish that statement. I'm on medication. I understand suicide. I understand what it's like to lose the best part of you to this illness. But I'm not ashamed, and I'm not embarrassed, and I'm not weak. And let me ask you this. How many people here think I'm brave for being up on this stage and talking about that? Raise your hand. Okay, I'm taking notes if you didn't raise. What the hell? Oh, Rosie, you have your hand up. I'm thinking, oh my God. So I'm asking for a point, right? Because it'd be like really, kind of creepy of me to say, yes, you're right. But this proves the stigma still exists. Because if I was up here and I was speaking about a physical illness, saying, my name is Michael Landsberg, I battle an illness called lupus, or whatever would be determined as a physical illness. And how many think I'm brave? You may have put your hands up, but you're not thinking that because there's no stigma around an illness like that. It doesn't take anything to get up for most people and talk about a physical illness. So I think the proof that the stigma still exists is the idea that you see me as being brave to get up here and talk about mental illness. And I would refute the characteristic of being brave just because this never, ever scared me. This never intimidated me. I never cared what anyone thought. And as a matter of fact, I hosted the show that I hosted for 12 years before I started speaking about my mental health. I had no idea that there was a value in it. None. But I found out that the value is huge. So I'm here to try to plant in your mind the idea that there's a different way to talk about mental health. You're leaders, in various fields all across this room. And I think it's just really important to understand why it is that we have largely failed to get rid of the stigma. I mean, I speak to people every day doing this, every day. And I hear from people every day who say, I could never share. I couldn't tell anyone, I couldn't tell my boss. Big fear. Therefore, if I can't tell my boss, I don't want to reach out and use the benefits that I have available to me. I mean, we live in a country where resources are minimal. Most people don't have access to the kind of resources that employees have, and yet they don't use them. They don't call their EAP. And that's a huge problem because it's there. And I'm a huge believer that suicide is the greatest tragedy of mental illness. But you know what's a tragedy too? It's tragic if you live with a mental illness like I've lived with and don't try for treatment. That you just live, even though you might say, I'm living, but I'm not alive. I mean, that's tragic because I know what it's like to have severe mental illness. I know what it's like to give up my life to this mental illness. And I don't want anyone to do that. I don't want anyone to ever, not everyone can be helped, right? There is treatment-resistant depression, RTMS. We're talking about that before. RTMS, my neighbor tried everything, every single thing, and was living in misery until he went for RTMS. And now I see him every day. What are you on a scale of 1 to 10? Call it the Sichter scale. 0 is the worst day of your life, 10 is perfect mental health. Not euphoria, right? Because, euphoria isn't mental health. Euphoria, it's the ability to experience it. So I say to him every day, what's your number? And he'll say 7, 8. And I say, that's so amazing. Because a year and a half ago, he would have said, well, I probably wouldn't have seen him outside. Because one of the things that we all experience with depression and anxiety, we retreat. We spend, I call it tied to the couch syndrome, where it's like you'll do anything possible to not have contact with people. So I think that there is the old school way and the new school. And I'm here to talk about the new school. Old school, I looked it up. Well, I found a definition of what suicide is, a description. Suicide is a complex multifactorial phenomenon with various risk factors and precipitating events. It is generally categorized as a manifestation of severe emotional distress, often linked to underlying psychiatric disorders. Who relates to that? Who goes, oh my God, I feel like somebody understands me. Oh my God, that's describing me to a T. No one is going to look at that, but that's the way we've done it. That's the way corporate Canada has largely looked at mental illness as something that should be shared in a clinical, polite, safe way. So to me, a better way than that is for me to show you this tattoo on my arm. This is the new way to do it, or at least the way I see it. 112408 is November 24th, 2008. YUL is the Montreal airport code. MH521 is Marriott Hotel Room 521, 0400, 4 a.m. in the morning. I sat on the edge of my bed. At 4 a.m., we were shooting Off the Record in Montreal at the Grey Cup. And I remember everything about this. And I remember thinking to myself, wow, this is why people take their own lives. And I remember thinking, I'm not going to take my own life because I've been through it before. So I had a measure of hope. Not a lot, because depression in particular is the illness that takes away hope. Even if there's legitimate hope for you, you don't see it that way. But I thought to myself, wow, I'm not a risk to myself right now. But I will be if I can't find my way out of this. I could not have gone on forever. Now keep in mind, this is an illness, not a weakness. This was not circumstantial. It wasn't that I didn't love my wife. It wasn't that I didn't love my kids. It wasn't that I didn't love my parents or everything about my life. It had nothing to do with that. I was sick, and I realized at that point, this is why people end their lives. And I made a promise to myself at the time, if I could, that I would share that experience. Because the power that really comes from hearing a speaker is the power of feeling understood. I was in Edmonton giving a talk 5 years ago. It was before the pandemic. And a woman came up to me afterwards, and she was crying. She was just so emotional. And I could tell that it wasn't sadness. I wasn't sure what it was. So I said to her, take your time. I'm going to stand around, and, when you want to talk, we should talk. She came back 10 minutes. I said, why are you so emotional? She said, because for the first time in my life, I feel understood. 5 years ago, I heard that. And I've talked in a way every day since that would allow people to feel understood. I like the idea of saying to people, you're never alone. But the truth is, in illnesses, when we battle them, whatever it is, we are alone to some extent. You can't share the pain. You can share maybe the experience of the pain. You can share the experience of going for an appointment. But what's really powerful, though, is if someone can say, I feel understood. So another definition of mental illness, 16 minutes. No, I'm going over. Too bad. Cancel your dinner plans. I'm going over. Mental illness, specifically major depressive disorder and general anxiety disorder, is characterized by a constellation of symptoms related to mood, cognition, and behavior. That's one way to define it. But to me, the best way I can define depression for you is to talk about what it does to me. So someone say, what's depression, Michael? Just go ahead. It's kind of rude to shout that out while I'm up here, but depression for me is when I come out of my house with my dog and I have the choice as I walk out, do I turn left? I live on Euclid at College, and if I go left, I end up on College Street, where there's tons of people, and I know people in the area, and I'm pretty well bound to see people that I know or just be in a social environment. So when I'm feeling good, I go left. When I'm feeling right, when I'm feeling crappy, when I'm depressed, I go right, because I don't want to see anyone. It's painful for me to talk to people. I have no confidence in myself, no belief in myself. Like, this may be bizarre to you, because I don't know when you walk your dog, if you have a dog, if you're evaluating your performance, but I am. I'm thinking to myself, oh my gosh, I got nothing to say. I got nothing to offer people. People are going to go, wow, I used to think that guy was, he was arrogant for sure on that show, but he was at least, interesting. I go right when I don't feel like Michael Landsberg. I go right when I feel like I've been lost to this illness. I've changed. I am no longer me. I am something else that I don't want to be. That's what depression is, not that definition. Depression is when you stand on your front porch and you try to determine by your mental health at that particular time, am I going left or am I going right? GreenShield. GreenShield. How many people here work for GreenShield or at GreenShield? I believe they call that a smattering of applause. Yeah. GreenShield became relevant in my life almost exactly a year ago. It was November 17th, 2022. It was at a restaurant called Donatello's. It was 1 year ago when I met for dinner with Brent Allen. Hi, Brent. Where's Brent? Brent Allen and Joe Blomley. There's Joe. We met there with Dave Cassidy as well. He was the one that introduced me to these gentlemen. Dave Cassidy is the president of Unifor 444 in Windsor, and you know that there's a link between Windsor, obviously, and GreenShield, and Windsor, and Unifor, and Dave, and Brent were friends. Brent invited Joe to come. Joe walked in for this dinner. Now, I had this idea for a mental health program. That was, I kind of looked at it like, this is my life going into this. Everything about my life, from what I've done for a living, which simply is talk, my experience with anxiety, which has been with me since I was 5 years old, and my experience with depression, which has robbed me of my life and has threatened my life. Everything goes into this plan that I had. But I knew that I couldn't do it on my own, right? Because, hey, lots of times I put stuff on social media and gotten 2,000 people to watch it. I don't need to create another opportunity to get a small audience, right? It's mental health. No one's going, oh my God, I got to find out what this guy's got to say on mental illness. So I had this idea, and Dave introduced me to Brent and Joe, and we met for dinner almost exactly a year ago. And Joe sat down, and he spoke for about 30 seconds. And what he said to me, I knew that this was going to happen. I knew it because he was thinking about the world of mental health the way I thought about it, thinking about his own mental health. If someone comes over to you right away and shares, that's a huge thing. You know that they are forward-thinking, and you know that they want to use their mental health or their mental health challenges to benefit someone else. So I thought, this is unbelievable, right? I mean, I kind of found my someone that I experienced this with. I don't know if you call it kinship, but whatever it was this link. So I said to him, I thought, okay, well, let's find out though, because he's part of a corporation. I said, do you want this, Joe, to be corporate? And he said, no. I said, do you want this to be totally safe? And he said, no. I asked him, do you want this to be sanitized? And he said, no. And I said, I can't hear you. And he said, no. I said, louder, no. And now the whole Donatello's is answering. I said, do you want mental health talk to be interesting? Yes. Do you want it to be sexy? Yes. Then he went, wait a sec. We doing adult films here or what? And I said, that's what I wanted to hear, though. I wanted to hear that there was someone that was willing to cross the barrier between safe and, in my mind, productive. That I wanted to find somebody who would agree with me that we got to attack this in a new way. So that was kind of the start of it. We went to the Leaf game afterwards. Maple Leafs beaten 3-2 at the time by the New Jersey Devils, who won their... See, you can't get it out of me. I'm still still yakking about sports. Terrible Argo game on the weekend. God, that's not off topic at all. So we knew at that point that we were going to find a way to be linked together. And here I am today. I don't know how, you're not here to hear about me talking about GreenShield, but we created this program called First Step, which is going to change the way employees across this country view mental illness, because they will be made to feel that somebody understands them. They will be made to feel that they can understand mental health. And that's really exciting for me. Let me tell you how I learned this, okay? I don't have long to tell you, but this story of the power of sharing, the power of simply telling your story is enormous. So in 2009, which was a year after the worst year of my life, I was feeling better, not great, but better. And I thought, I've never spoken about this on TV, but we had a guest on the show, Stéphane Richer. Anyone in this room know Stéphane Richer, former Montreal Canadian? Great hockey player. And I read, just before I left my desk, I read that Stéphane Richer had battled depression in the 1990s. I have no idea why I just said, Stéphane Richer has battled, like why I said it like that, I have no idea. But Stéphane Richer was waiting in the green room. And I said to him, you know, Stéphane, can you come outside for a second? And he said, what's up? I said, look, you don't know me. I've never met you before. You don't owe me anything, for sure. You're a guest. But would it be okay if I asked you about depression and how you're doing? And he said, I'd rather not talk about it. It's very painful. And I said, I understand. I'm glad that I asked you. But if you'll talk about it, would it help if I talked about it? And he said, what would you talk about? And I told him my story, which at that point had been a lifetime of anxiety and I guess about a decade of depression, which I'd never spoken about on Off the Record because I thought, who would care? What's the benefit? But I wasn't ashamed. I never thought about it. I just, everyone in my life knew. So he said, okay, let's do it. So now my life is going in this direction or this direction. I'm not saying up, I'm just saying in general, I'm heading this way. So we go to the third commercial and I say, hey, Stéphane, before we go to break, tell me, how you doing? And he goes, I said, with depression. He goes, you know, I'm okay. You know, it's not great, but I'm living my life. I said to him, you know, I'm really interested how this affected not your hockey career on the ice, but how this affected the way you thought about hockey and the way you thought about you. And he said, imagine, Canadian kid, drafted by the Montreal Canadiens, Rookie of the Year in the NHL, last Montreal Canadian to score 50 goals, win the Stanley Cup with the Montreal Canadiens, and all I want to do is get off the ice, go home, and get into bed. He said, I never experienced a moment of joy playing hockey, winning 2 cups. Imagine that. And I was like, wow, that is incredibly powerful. And I said, well, you know, for me, it's obviously I haven't had the same successes that you've had, but I understand that loss of the ability to experience joy. And that's what I've spoken about every day since, because after the show was over, I went home and the show went to air at 6 o'clock, and I don't know, 6:45, I started getting emails that basically all said the same thing. And this totally shocked me. They all said, hey, Michael, I'm sharing with you something I've never shared with another human being. Like you, I battled depression, but I've never told anyone. And it wasn't until I watched you and Stéphane talking about, like, we didn't say anything brilliant. I mean, I thought he was amazing in how deep he went. But, you know, like to me, it was just like normal conversation. He said, but when I heard 2 men speaking about depression, without shame and embarrassment, and most of all, without seeming weak, when I heard that, I realized that's me, and I can do it. So I'm telling you, this is what they wrote, I'm telling you something I've never told another human being. I too have battled depression, and I'm going to go to the doctor tomorrow. And that started to change my life because I read, you know, more and more of those, and I'm thinking, you know, how did that happen? I had no idea that we were doing any good. I was just trying to do an interesting TV show. So 2.5 years later, I get an email. It says this, hey, Michael, it's Tyson Williams from North Battleford, Saskatchewan. You don't remember me, but 2.5 years ago, you and I exchanged emails 5 times. And I did remember him because, as I said, these were life-changing for me. He said, I need to be honest with you, and I wasn't. When I messaged you, and just before you returned my message, I was in my closet with a belt around my neck. And I heard the computer go. And I thought, okay, well, I better go and, you know, see who it is. I'd written a letter to my daughter and to my parents. And basically what I said was, you know, I'm sure you'll be sad now, but you'll all be better off without me because what do I bring to anybody's life? Which is not an uncommon thing to think with depression. So he said, I wrote that back to you, and I said to you nothing about that, but I wrote back to you and said something like, oh, you know, good for you for talking about it, but I implied that it was too late for me. And then he said, I went back to my closet, put the belt back around my neck and said, okay, Tyson, this is it. And then the computer went again, and we went back and forth 5 times. He never told me any of this, so this isn't me saying, well, look what I did. He told me that he was hopeless, and I said, what do you got to lose? He said, you know, I can't go for help because I'm a small town guy, I'm so embarrassed, so ashamed. And I wrote to him and said, what do you have to lose? You've described your misery. How bad, how much worse could it be, actually? So the upside is maybe you get better and get your life back. And the downside is what? That someone in your community knows that you battle depression? So he said, the last time you responded to me, I heard the computer go, I looked at the computer, and I said, that guy doesn't shut up even in emails. But he said, it resonated with me. The next day, I went to my family doctor, and here we are 2.5 years ago, 2.5 years later, and I'm happy I'm alive. And the only reason why that happened is because a couple of guys on TV shared. Wow, I mean, that story, anyone not like that story? It may be really weird if you put your hand up, to be honest with you. But pretty gutsy. I really admire that. But it gets better. I mean, I will buy anyone a gift after this if you don't think this story is amazing the rest of the way. So 2 years after that, I get an email from him with an attachment. The attachment is a picture with Tyson Williams holding a newborn baby. And he says, this baby is alive because I watched 2 people share on television. Wow. But that's not the end of it. I'm kind of speeding through it now. There's other elements, which unfortunately I can't give you right now. Now you want them, don't you? This is what he said, or how I'm going to tell it. 5 years ago, I got an email from Tyson Williams, and it said, will you be the best man at my wedding? I never met him before. So he got married at Spruce Home, Saskatchewan, which is an hour north of Prince Albert, Saskatchewan, which makes it 2 hours north of anything that anyone from Toronto has ever experienced. But I went up there because, like, who's going to say no? Never met him before, no idea, anything about his life. I got up there, and I'm standing on sort of a stage with the Justice of the Peace. He's walking down the aisle. He's walking with his parents. He's holding his daughter's hand, the one he wrote the note to, and he's holding his newborn daughter, who's now like 2 years old at that point. And I think to myself, wow, how cool is that? Like, how did this happen? I also thought to myself, wow, why would he have told me to wear a suit when it was a Saskatchewan Roughriders themed wedding and every person in the audience had a Saskatchewan Roughriders jersey on? And he thought that was funny, which I guess it was looking back on it. But that taught me the value of sharing. Am I running out of time here? I mean, it says 19 seconds, so I guess that would be an indication that I am. Can I take 2 more minutes? I'll just ask Zahed, can I take 2 more minutes? How about 3? So I want to leave you with a few ideas. I want to leave you with the idea that you're going to see something really unique from GreenShield. First step. We named it First Step because our goal, amongst others, mostly our goal is to educate people about mental illness in a way that they never have before. So maybe they'll say, oh, he's talking about me. Or maybe they'll say, somebody understands me. Or maybe they'll become better caregivers to people they care about because they understand what they don't understand. So First Step also is designed, hopefully, to get people to reach out and take that first step, which could mean calling a family doctor, which could mean talking to HR, which could mean reaching out to GreenShield for benefits, which could mean reaching out to Inkblot. People need to take that first step, but often they need to be convinced to take that first step. So watch for that, and watch for, I got so much I want to say. Fuck it, I'll just keep going. Zahed, too bad. Did I swear? Yeah. Anyone mad? Disappointed? I just want you to know that there is someone who understands you. Because you're out there in this room. I'm not going to ask you the question, how many of you have battled a mental health challenge or are battling one, because that's your business. But I'm up here to tell you that you are understood. I'm up here to tell you that what you have experienced is exactly the same thing that all of us have experienced. And I'm saying not that depression is identical in everyone, but there are characteristics of depression and anxiety that are identical in every person. I've given talks to 200, maybe say 1 million people total. Seems like an appropriate exaggeration, but made me feel good about it. I can tell you that I have said, anyone who has not experienced what I'm going to describe right now, put your hand up. No one ever has. So when I tell you these two characteristics of depression, I can assure you that every person has felt it, which means if you've experienced it, you know you're understood. But even more importantly, if you sleep beside someone who's battling depression, now you get a glimpse into what's going on in their brain. Two things. Number one, just like Stéphane Richer said, the loss of the ability to experience joy. It's not that good things don't happen to us when we battle a mental illness. It's not like if you buy a lottery ticket and you have depression or anxiety that you have less of a chance of winning. It's not that. It's that you can't feel the joy that comes from life, the loss of the ability to experience joy. It's like when you have a cold and you can't taste and you take a bite of pizza and you think to yourself, I can't taste this pizza. Imagine if someone yelled at you, try harder. Like, that would be like really stupid. That's what we say to people with depression, that person that sleeps beside you. Maybe you've said it to them. Loss of the ability to experience joy. And the other one, which for me has been particularly crippling, is the loss of self-esteem. Every person who's been through it will tell you, oh, yeah. So here I am today standing on this stage talking to you guys. And I feel pretty good today. Not great, but pretty good. So I can look forward to this. I'm standing over there waiting to be introduced, and I'm saying, wow, I'm so glad that I'm here. I just want to share. I want to be part of, I want to get something good for people. But on a bad day, I'd be standing there thinking, God, why did I say yes to this? Oh my God, this is going to be so terrible. People are going to know how bad I am, how bad I is. And everything that comes out of my mouth, I'll be evaluating as it comes out of my mouth. And it doesn't matter whether you're a broadcaster or a public speaker, whether you work at GreenShield or the Globe and Mail or anywhere, we all lose confidence in ourselves. We all have things in our life that we know we can do. Until mental illness hits us, then we don't believe we can do them. And if you know that, maybe it'll help you. And if you care about someone with a mental illness, maybe it'll help you. My name is Michael Landsberg. I battle an illness called depression and anxiety. I'm on medication. I will be the rest of my life. I understand suicide. I understand giving up chunks of my life to this illness, but I'm not ashamed. I'm not embarrassed. And I'm not weak. Thank you.
That was awesome.
Thank you.
Thank you so much for those remarks. It was truly inspiring, and the work that you're doing to normalize the conversation around mental health is so needed in this country. And so, thank you, just as a human, as a journalist, as someone here on behalf of the Globe and Mail. Thank you so much. Before we close out the program, I would like to invite Elder Wabigoon back to the stage.
Wow, could we have another round of applause for Michael Miglitch? So, bonjour, Indoe Maganato. Ani. Minwa. Minwa means again. And so, bonjour. Some people mistaken it for bonjour, as in hello French, but it's bonjour, bonjour, Anishinaabe-Moan. So when we open a circle, as we did earlier, we come full circle and close the circle. This morning or this afternoon, I came here with mashkaki nibe, medicine water, and I opened with it. In our creation stories, water's original instruction was to move. Move everywhere in search of life. Search for the two-legged, the four-legged, the plant nation, the tree nation, the flyers, the crawlers, and hydrate them. Water is Mother Earth's blood. We must look after this life-giving force. Moving forward from this afternoon, I ask you to talk to your water. Water saved my life. I truly battled something as well that brought back memories of when I was a teenager. And I found this relationship with water. And I started to talk to it when nobody else would talk to me. And we became very close friends. Then I found out that it had emotion. Then I learned about Dr. Imero Emoto. And his vision, people thought that he was a little crazy for what he thought about water. And he thought that when he spoke to water, and then he froze the water, and he spoke nicely to it, came back with these beautiful crystals. But when he spoke to it harshly, and he froze it, it came back with these horrible shapes. And you could see the meanness, the ugliness in the shape. So it shows that he proved that water has emotion. So as I said, moving forward from this afternoon, I ask that you talk to your water, sing to it, honor and treasure it, for water is very sacred. All forms of water are sacred. Water in your mother's belly when you're being born is very sacred. We have ceremonies for that water. Our precious water needs us all to pay attention to it and how we're looking after our water as it's calling on us to help it. I've heard and answered the call. The water's sick and it needs our prayers to help heal it. It begins with by putting out a glass of water, maybe beside your bed, and saying thank you or saying miigwech. Know that water is alive, and I'll keep saying this over and over again when I come back here over and over again. I'll tell you, water's alive, it has emotion. Spent many years with talking and singing to and about water. My husband will attest to that. I know that it responds to having good words spoken to it. Water keeps us alive, and it's the most important medicine for us. Let's start engaging with it. If you go for a walk by the water, acknowledge it. Like I said earlier, talk to it while you're doing the dishes. Say thank you when you drink it. Pray for those with too much water and those with not enough. It starts with the small things. I call you to help the water in any way you can. I'm just going to ask those who can stand to please stand, face the eastern direction, and we're going to sing the song that was gifted to me in a vision, and send everybody home in a good way. Way high, oh, way high, oh, way high, dee, oh. To the southern direction. Way high, oh, way high, oh, way high, dee, oh. To the western direction, where the ancestors rest. Way high, oh, way high, oh, way high, dee, oh. Lastly, to the northern direction. Way high, oh, way high, oh, way high, dee, oh. Please sit. So it's with this song and these words that I urge you to remember the spiritual connection that we all have with Mother Earth and the water. We have to go back to the land and search the medicines, the plants, speak to them in a good way, to let them know you're there in a good way. We lay tobacco before we pick our medicine. And our skirts are worn at a certain height so that the plants will know when we go to pick it. Our skirts will just brush the tops of it so that they know we're coming in a good way, and they'll tell the relatives down the way that we come to pick in a good way. I like my going off on my script. So live the lesson that nature shows us of living in harmony as one with all our relations. I say miigwech as I honor those who came before me, and I say miigwech as I close this space. Apachiko chi miigwech pisandawiye. Thank you all very much for listening. Miigwech, safe travels home.
Thank you very much, Elder Wabigoon. That concludes the formal part of our discussion for today. So on behalf of the Globe and Mail, thanks to everyone who is here today, whether you're in person or watching virtually. Thank you for being here and being part of this conversation. And also thank you to GreenShield for making this event possible. As we're filing out, we're going to replay the video because some people didn't get a chance to see it. There were some requests to show it again. And I would just like to invite everyone to the reception that's going to be taking place just outside the halls after this. So thank you so much, everyone, for being here.
I'm here today to share my story because I'm very grateful. I bought my medications out of pocket. Everybody knows it's difficult to do that. It's expensive, but you do what you have to do. It's not a good feeling. I wish I can describe it to you, but I can't. It's just stuff that you need, medications that you need.
I love seeing the change in people when you are able to provide them with sometimes simple things. And I feel like the essential medicine is meeting a basic need. It's a prescription, and we forget how important and how much of an impact that can make on someone's lives of being able to take an antibiotic when I'm sick or take those diabetes medications when I need them.
When I was approved, I got a phone call saying that, yes, I'm qualified for the program. And I wish that Emma, the lady that called me, had seen me. I told her that you really had me dancing, and I usually don't dance. Nobody get me to dance. So yes, I was excited. Yes, I was very happy.
Everyone's human, everyone's got things going on in their lives, so it's just nice to be able to offer something to help individuals, in this particular case, the Essential Medicine Program and medication coverage and prescription coverage, to be well.
I did it, and it's working for me because nobody needs to go without medications.